Good morning, friends. We have come to this end of this oppressive year 2020, and this is our last CME program from CGP. I welcome you all for this program, and without wasting much time, I hand over the mic to our president, Dr. Sujatun Attar, madam, to give our presidential address. Over to Dr. Attar.
Thank you, Dr. Anil. Good morning, friends. I welcome you all on behalf of IMA Mumbai branch for our multi-speciality webinar, where we have eminent speakers to update us on their respective fields. Friends, I would like to make you all aware regarding the CCI notification, which the Ayush Ministry has issued on 20th of November, where the Ayush doctors are allowed to perform surgeries. For that, on 8th of December, we had agitation in our branch, and on 11th of December, we had a press conference on no to mixopathy, and thereafter we had met the collector of Mumbai and given him the memorandum. And MMC, after a few days, has given a notification that all allopathic doctors should put MBBS before their MS or MD degree so that they can be differentiated that they are allopathic doctors from the Ayush doctors. And each one of you all should make your patient aware about this so that they know that they're going to the right doctor and not causing more harm to their health. And friends, I would like also to announce that our branch is privileged to receive the following awards. Anil, just share the screen. Our branch has received the following awards in and is highly obliged to IMA Maharashtra State and IMA Headquarter Office Bearers. We dedicate these awards to each and every member of our branch who has worked very hard in making this branch a vibrant and premier branch. And friends, let me tell you that on 6th of December, IMA Maharashtra State has bestowed upon IMA Mumbai branch 5 branch awards and 7 individual awards. I'll just have put it on the screen. The Maharashtra State Awards are the Best Large Branch Award, President Appreciation Award, Corona Pandemic, exceptional work that we had done at Dharavi, and we have created a module which was also accepted worldwide. I went by the WHO, Dr. J.S. Sikchi Award for Locals Faculty of IMA CGP, IMA News Bulletin Award, President Appreciation Award for Maha AMSCON 2020, where the first time we had taken a digital professional help for a digital online CME, and thereafter everywhere we had this online webinars going on. And President's Gratitude Award to our own, Dr. Shiv Kumar Uttare, MMC President. He received the Maharashtra State Award. And IMA MS Corona Award was given to Dr. Sujatun Attar, Dr. Anil Awar, Dr. Pragji Waza, Dr. Surendra Shignapurkar, and Dr. Sachin Patarkar. And Corona Matter Award was given to Dr. Chitranjan Bhave. At the national level, on 18th, we had received the 3 branch award and 5 individual awards. The Best IMA Local Branch Rotating Trophy of Gujarat State Branch, IMA Best CME Scientific Program Award for the number of programs that we are holding and the quality of our program for webinars. IMA Community Service Award to be given to a local assessed as the best branch for organizing community services during the year. IMA National President Appreciation Award for Best Adjudged President was given to our President Dr. Prakash Borana, who was for 1819. IMA Dr. A.K.N. Sinha Award was given to our own Dr. Shiv Kumar Uttare. Dr. IMA National President Appreciation Award for Lifelong Services was given to Dr. Anil Pachnekar. And IMA National President Appreciation Award was given to Dr. Sujatun Attar. And IMA National President's Appreciation Award for COVID Care and Control was given to Dr. Sujatun Attar. Friends, these are the feathers in our cap with the help of everybody who has made our branch a vibrant and a premier branch. Our forthcoming events, which I would all like you all to now block your date, is 3rd January of the new year 2021, where we are having a cricket tournament, and that is going to be live. So we request everybody who wants to participate with your family and your children and if, personally, please register your name at IMA office for that. On 7th of Jan, also we are having a webinar, JJ Merchant Oration by our own past president, Dr. Prakash Burana, and we are having e-Bima elocution. Please participate and give your names at the branch so that we can contact you. And please block your date for 7th Feb 2021. That is our Golden Jubilee Annual Conference, which we will be informing you all later where the venue will be there, but please give in your names at IMA office for and block the dates where we will be having a hybrid where the venue also will be told to you. Thank you very much. I hand over the mic to Dr. Anil Awar, Assistant Director, IMA CGP.
Thank you, President Madam, for your kind words. It was really a good year
Good
for
year.
IMA because we got so many prizes from the state as well as from the national headquarters.
Yes, definitely.
Yeah, thank you and congratulations to all award winners. Now we move on to the CME, and the first speaker is Dr. Nita Varti. I'll just introduce Madam. Dr. Nita Varti has a very illustrious biodata, which I took a lot of pain in, making it a small. Dr. Nita Varti is the mentor of laparoscopic surgery in the Department of Gynecology and Obstetrics at Sir H.N. Reliance Foundation Hospital. She completed her master's from Mumbai University, after which she went on to receive her formal training in laparoscopy from Friedrich Schiller University, Germany. She has also trained in laparoscopic oncology at Whipps Cross Hospital, UK. She is renowned gynecological endoscopic and robotic surgeon and has performed more than 10,500 endoscopic surgeries and is credited to have removed the heaviest fibroid in the world, weighing 3.4 kgs, which was acknowledged in the Guinness and Limca Book of Records. Her team has won the prestigious Best Research Video Award at the 2016 American Association of Gynecology Laparoscopists Annual Conference. She has developed the laparoscopic Shirodkar sling surgery for uterine prolapse. She is an expert faculty conducting various workshops for advanced laparoscopic and robotic surgeries. Today, Dr. Varti is going to talk us on current concepts in management of fibroids. Over to Dr. Nita Varti.
Good morning. I bring greetings from Sir H.N. Reliance Foundation Hospital. This is the place where we work, and a state-of-the-art situation in the operation theater where we do all the surgeries that I'm going to show you today. I would like to thank all the office bearers and the members of the IMA for the wonderful opportunity today on a Sunday morning to share some of my thoughts and my experiences. I'm extremely impressed by the number of awards, and all this is in the service of humanity. I think it requires a big kudos and a big clap for the IMA Mumbai. I'm honored to be sharing screen with all of you. It gives you, when a person walks in, we have small 20-something girls walking in the clinic with very worried parents with an abdomen like this. It is really, really heart-rending, and your heart goes out to the family because they're just not aware. At 20 plus, this girl is not aware. I've taken this topic today because as family physicians, we need to have an understanding of the growing problem of fibroids and endometriosis. And the first point of contact, I feel, is with the family physician. So I think we should go back to the era where we had routine family checkings, counseling, physical examination of all these girls. Because what the mind doesn't know, the eyes don't see. A girl does not understand. I've got girls coming to me saying that the physical trainers have sent them to a doctor because the abdomen was not going down. And these fibroids grow ever so slowly. And that is why we don't realize that there's something growing in the abdomen. This is a large fibroid, and over years, this is something to the tune of an 8-month pregnant uterus. And we cannot even see the whole fibroid in one frame. So how do you handle a problem like this? Whenever there's a mammoth problem, what we've learned is compartmentalize your problem and treat each compartment by itself. So what we are doing now is we are actually going to the blood supply of the fibroid, and with these clips, which are quite effective when they block the blood supply and quite delicate when you want to remove them. This is how we are blocking the blood supply to the entire fibroid, and slowly you'll start see blanching coming out the uterus. And what we've done is we've only blocked the arteries. Now we are mapping the fibroid so that the uterus, the ovaries, the tubes retain their tubo-ovarian relation. We don't damage anything, because in a fibroid of this size, you never see the fibroid or the uterus in its entirety in one screen. So once you start cutting, you lose sense of direction as to what needs to be cut. So when it is pre-marked, it is always better. We've done so much of blood control, and yet you would have some bleeding because the uterus is abundantly supplied. Now with the fibroid removed and the bed sutured, you can actually see a lovely uterus. And at the end of all that, the blood supply that was blocked, that means what have we done? We've actually used this as a tourniquet. The pelvic side wall is back to its normal self. The uterine artery beautifully pumping blood back again. And one looks at the ureter to check the integrity of the ureter, because in this area, the uterine artery and the ureter are extremely close to each other. This is what has happened. The uterus, very nice. And this uterus will again keep shrinking for a while to go back to its normal size, maybe a little bulky. So what we've realized is, first we look at the hemostasis, we enucleate the fibroid, stitch the bed, get these out. So once the clips are out, the uterus is back in its glory of all the blood supply. And you will notice that there's absolutely no trauma to the uterine artery. Normally, if we tied a knot, or the suture sits tightly, then you could have a little trauma, which also doesn't happen. These clips are extremely delicate. You can also use harmonic to get it out. And the biggest problem that happened when Amy Reed in the US had a sarcoma which was scattered is that there was a problem with morcellation. Now we do morcellation inside a bag. So many times the patient will ask you, will a big fibroid like this possible laparoscopically? How will you remove the fibroid? Will it become pieces? Yes, but the fibroid is put inside a bag. So this bag is an abdomen inside an abdomen with channels for a morcellator. And this morcellator has a blade which rotates at a very high RPM, and it cuts and sucks out the fibroid. Fortunately, nothing is spilled. This is the final picture. And what we are seeing is an interseed or an adhesion barrier, which will prevent infections. Now, different ages, the myometrium behaves differently. Normally, we are able to tackle the fibroids during reproductive age, pregnancy, and puerperium, because this is the time the patient is in contact with the gynecologist off and on. But what I'm concerned about is the late 20s and the postmenopausal age, when the physicians should put in effort and look at the patients, tell them about follow-ups, tell them about sonographies. This is how it looks. This is a fibroid being removed. The bed looks really very disorganized when you remove the fibroid and stitch. But at cesarean, you will see the uterus has a tremendous capacity to heal so beautifully. No adhesions if you use the energy sources properly. Once you go to the symptomatology, normally you would have patients complaining of a little bloating, pressure symptoms, incomplete defecation, and most commonly, urinary frequency. A vaginal discharge if the fibroid forms a polyp. And if the fibroid grows closer to the uterine cavity, then you'll have menorrhagia as the most important symptom. Pain is very, very unlikely in a fibroid unless it is degenerating out of its blood supply, or it has associated endometriosis, which is possible because of retrograde menstruation happening with the fibroid bed. These are the pressure effects where both bladder and bowel can get compressed. These are the fibroids that we started with, smaller, difficult locations, little bigger, little bigger. And the Guinness Book, which happened in 2020, I think 2000, that was, I think we'll complete 20 years now, because it was on 25th December that we did this case. And at that time, 3.4 was a huge fibroid. We've grown since then. And I think we've done really good as far as the fibroid management is concerned. And now these are the fibroids that we've removed: 3.5, 5.6, and the largest was 9 kilos and 27 grams. What are the investigations that we should do once a fibroid, once you notice fibroids? The blood biochemistry is routine, your hormones, CA125, CA19-9, and also LDH, because though there is no proper risk assessment score as far as uh, sarcomas are concerned, we found the LDH isoenzyme 3 is very high in cases where there are atypical fibroids, which I will be talking about shortly. Ultrasound, of course, to rule out adenomyosis and also the vascularity of the fibroid. Follow-ups should be regularly 6 monthly for bigger fibroids if you're only going to observe them and not do surgery or not treat them, and post-surgery yearly, especially because recurrence is a big problem. MRI is very important. So when you send patients for MRI, there have to be a few things that the MRI person should understand. One is the quality of the fibroid, the texture of the fibroid, so that you're looking at adenomyosis or fibroid or atypical myomas, because that is a very important thing. And the atypical fibroids are growing in incidence very rapidly. So fibroid mapping is something that the MRI person should be very well aware of. And when we are dealing with multiple fibroids, especially, one should ask for detailed description of each and every fibroid mapping, which is 1 centimeter and above. Because normally we see reports saying that multiple fibroids throughout the uterus, with the largest being 9 centimeters or 10 centimeters. If a surgeon is going to remove every single fibroid, including the 1 centimeter one, I think the MRI doctor can spend a little more time so that we get the details, at least the number, as many as can be counted, because that will help treating. In the management options, I think observation is by far the best if the fibroids are not troubling, but monitoring them yearly or symptomatically is very important. The red flags when you're keeping a patient for observation would be symptomatic fibroids, large ones, fertility is desired, unclear anatomy, and excess vascularity. When we treat them medically, normally you have either OC pills, combined OC pills, or you have progesterone IUDs. All of these will try and decrease the size of fibroids, working on the fibroid cells and on the vascularity of the fibroids. Then you have selective estrogen receptor modulators like tamoxifen, raloxifen, progesterone receptor modulators, GnRH analogs, and anti-estrogens, out of which I think at the moment for irregular bleeding, menorrhagia, we use OCs a lot. Ulipristal, which is a selective progesterone receptor modulator, is in a good medical management therapy. Here you give 5 milligrams every day, daily. The problem with this is that you need to look at the endometrial lining at all times, because the endometrial lining becomes glandular. The glands increase in size and it looks like cystic glandular hyperplasia. Fortunately, the moment you stop ulipristal, it regresses within 6 months. So it's not really a danger of endometrial hyperplasia, but a monitoring of that endometrial lining is important, and also the liver function test, because liver function is sometimes altered, and any indication of alteration of liver function should make you stop the ulipristal. Normally, we give it for 3 months, take a break, assess the fibroid. If it's working, maybe give for 3 months more, but it can't be given forever and ever. The GnRH analogs are good because they shrink the fibroids up to 20-25%, but can be used only for a limited time because they cause bone loss and they cause all the anti-estrogens like skin, hair, bone loss, all those problems, liver. So they can be used as a temporary therapy while you change the anemia status of the patient, build her hemoglobin, or post-surgery when you want large fibroid beds to shrink. In the future, we are looking at next generation sequencing, which will target the extracellular matrix of the fibroid. But this is still a little away from us. Alternative medicine is used by many of our patients, though we do not dissuade them. I'm sure there is some effect of alternative medicines and a science behind them, but the monitoring should not be stopped when alternative medicine is used. Now, coming to every time a fibroid is detected, the first question that a patient will ask me is there anything other than surgery that can be done? Yes, interventional radiology is now going ahead in leaps and bounds. We have uterine artery embolization since 1995, where a French group discovered that, and the magnetic resonance imaging programmed focus ultrasound, which the European Union approved in 2002 and the US FDA approved in 2004. A word of caution, how does it work? The pellets block the uterine artery. The uterine myometrium survives because it has a collateral supply, whereas the myometrial vessels, being end arteries, they cause ischemic necrosis of this fibroid. In the magnetic resonance imaging, it is basically thermal myolysis by acoustic cavitation, which is MRI guided. Now, we have been seeing a lot of patients. So these therapies, when used, have to be chosen well. Whenever a patient, it is not possible to get the patient anesthesia fitness, where there are multiple ailments and you want to temporarily treat them, this can be used. You can use them for smaller fibroids, you can use them for adenomyosis, but we have been doing a lot of interventions, post-interventional procedures, and I feel we need to have a little understanding as to what. Now, this patient had a large fibroid. This size of a fibroid preferably should not be taken for an uterine artery ligation. What it does is it causes an aseptic inflammatory response. You have a large mass there, completely degenerated because it's lost its blood supply. There is ischemic necrosis happening. And you have the omentum, the large bowel, everything. Of course, this is an aseptic process. This is the large bowel adherent. And this is the omentum. This is the fat around the rectosigmoid. Then you have ileal loops. This is another ileal loop. So you can see that the entire fibroid mass has been covered with adhesions. And in case there is any kind of infection happening in this mass, then there is a risk of septic shock. So a word of caution, before you use this, choose the patients well. Now, this particular film is a patient who wanted childbearing, had multiple fibroids, and has undergone a MRG HIFU, that is the high intensity focused ultrasound. This is a large fibroid. When there are multiple fibroids, a patient desires fertility, one should be a little wary of using this because these are fibroids which were very close to the endometrial cavity. As you can see, and we are trying to get the endometrial lining off so that we can protect the endometrial lining and remove the fibroid, but that gets totally thermally damaged with this. So we have to use all these options with a lot of care in choosing patients. So when fertility is desired, large masses, when your diagnosis is in doubt, because you don't get a pathological correlation in these fibroids, you get surgically adherent bladder bowel if she's had a previous surgery, and then you risk the bladder and bowel. And of course, the proximity to the endometrium should be checked. Surgical management, we've seen how a laparoscopic myomectomy is done. You can always do a hysteroscopic myomectomy and not put a laparoscope if the fibroid is entirely inside the cavity of the uterus like this one. This is a cavity which is completely full of this fibroid with a little bit of the fibroid in the muscle of the uterus. So what is done is through the hysteroscope, which is 3 millimeters, and the entire sheath being complete together, a centimeter thick, is introduced. The cavity, which is actually a potential cavity, is bloated with using either saline or glycine, and the fibroid is resected completely. So in this case, you got, this is the end of the procedure. You've got the entire fibroid out and the cavity is beautifully seen, completely empty. And no surgery required at all. This can be done as a single day procedure. A word about recurrence, because every time a patient comes, they also ask us, will it recur? Endometriosis and fibroids are two things that is very difficult to say that this won't recur. And the incidence at the moment is so high that 80% of women, when they reach 50 years of age, would have got some kind of a fibroid. Out of hysterectomies done, 40% are because of fibroids. And when we look at the recurrence, after a myomectomy, a patient requiring hysterectomy is 10% in 5 to 10 years. After doing a uterine artery embolization, the reoperation rate is as high as 33% in 1.5 to 5 years. And after a magnetic resonance focused ultrasound, it is 59% in 5 years. So all this data needs to be looked at. Now, sometimes a patient will come, she's finished childbearing, there are multiple large fibroid. This is the size of a uterus, which is almost 36 weeks. It's touching the liver. How would you do a hysterectomy? So the patients have these concerns about whether a hysterectomy is possible laparoscopically, and would anything be left behind, because they feel that those small punctures, it is not possible. Now we have graduated, we have evolved since the time we started doing laparoscopies. And now if you notice, we go for the blood supply, because the uterine blood supply holds the key to a lot of things. This is the entire uterus, you can see going right up. It's gone right to the rib cage. We haven't even gone to the uterus. Just take the round ligament, dissect the uterovesical fold, and the uterine vessels are taken. Normally, if you saw the earlier film, we take the uterine artery alone, not the vein, because then the specimen blood also drains out and we save on the blood that we would have lost in this huge specimen. The specimen is completely blanched. That means before you've even started doing a hysterectomy, by taking those vessels and decreasing the blood supply, the surgery is almost over before you've started, and it becomes extremely safe. Endometriosis is one of the common things that happen when there are large fibroids. Sometimes what happens is we are mistaken as far as the radiological look is concerned. What is reported as a fibroid turns out to be an adenomyoma. This is an adenomyosis, and it's a redo adenomyosis. We've released all the adhesions, and as usual, we've taken the blood supply. Now, a lot of times what happens is, we go by the idea that we've learned during anatomy, that there is one uterine artery which comes as a branch of the anterior division of the internal iliac. And once you use that, a staple on that, then there is no other problem happening. Whereas when you have these big fibroids or redo cases, we have seen that there are multiple arteries. Now, in this case itself, you will notice that there are two arteries supplying on either side. This is the study that we did and published about, and the word is coined by us saying stool. Stool is selective temporary uterine artery ligation, what we've been seeing. This was in the Congress of the AAGL, the American Association. This we'll keep for another day. Fibroids and myomectomies during an ongoing pregnancy for red degeneration. What I want to talk to you about today mainly are the current kind of fibroids that we are dealing with. And some of those fibroids are not the normal fibroids, they are called stumps. So what are stumps? Stumps are smooth muscle tumors of undetermined malignant potential. That means it is defined as a fibroid which cannot be unequivocally put into the bracket of either benign or malignant sarcomas. And there are a huge amount of cases where we don't find normal fibroids. What is the importance of these cases? The importance is they have a very high recurrence rate. They also grow. Now, this particular case is a case of disseminated peritoneal leiomyomatosis. That means there are multiple miliary fibroids all over the abdomen. And this does not require surgery. All it needed a biopsy. Once the decision was made, the diagnosis on histopath was made. He was given GnRH injections, Zoladex, Buserelin, or 3 injections, and there was absolutely no fibroid left whatsoever. Intravenous leiomyomatosis. Now, this is another kind of atypical fibroids. These fibroids form inside the vein walls. That means the lumen of the veins have these fibroids. Very difficult to operate because you can't get hold of the blood vessels. So the blood vessel is taken as an entire arteriovenous channels, you block them and you see fibroids which are globular, cylindrical, comma shaped, dumbbell shaped. The kind of shape that the vein takes, you will have these fibroids. This was discovered by Birch, and there are two hypotheses saying that they found from the walls of the vein, or there are fibroids in the uterus which invade the vein and grow into the vein. Now, these can recur as high as 30%, so entirely should be removed. And they can also travel from the uterine vein through the iliacs, the IVC into the atrium. So these can be dangerous. They need to be checked and they need to be excised completely. Now there are fibroids which are routine fibroids and atypical fibroid. This one, when we started, looked like an absolutely normal look uterus. This was done in 2006. So this patient has been following up with us, and there was no capsule, nothing that you could enucleate. So this is what is called as morcellation in situ. That means while the fibroid was being removed, once the blood supply was taken care of and we knew that the bed wouldn't bleed more, we did a morcellation while the fibroid was inside. Now this could not be morcellated. There were just pieces and pieces of fibroid. At that time in 2006, the understanding of stumps was not so much as it is today. And this was retrieved. Patient came back after a few years, I think 2011 or so, with this picture. So this is diffuse peritoneal leiomyomatosis. Probably the understanding is the fallen fibroids or pieces or ones that remain behind start growing on the peritoneal lining. So this is a peritoneal fibroid. They grow everywhere on the peritoneum, pelvis, abdominal cavity, everything. At that time, we had an oncosurgeon with us, and looking at this fibroid, we were not capable of handling these. The understanding about these fibroids was not very good. So we opened up this patient and removed all these fibroids, asked her to go through pregnancy as soon as possible, which did not happen. And she came a few years later, about 2-3 years back, with this picture in the abdomen. We did MRI studies, mapped all the fibroids, had a fair idea as to how many, what were there. Again, there were large masses. Now, this time we went through laparoscopically. Now, these are fibroids hanging from the abdominal wall. That means anywhere there is a peritoneal covering, the fibroids draw blood supply from that. Now, this is where the inferior epigastric artery and a confluence with the other artery coming from up has given way to this fibroids, and the blood supply is absolutely random. So it is difficult. In the fibroids which are from the uterus, you can go to the blood supply, uterine artery, maybe another uterine artery, or one or two more channels, and you take care of them. But here you have channels all over the abdomen. So word of caution when we do fibroid surgeries, or when we see these multiple fibroids, that means these fibroids. Now the diagnosis of this fibroid, when we actually did this fibroid in 2006, was a cellular fibroid. Now cellular fibroid forms into the area of atypical fibroids, and the criteria are all histological. So if you have mitotic figures, which are less than 10, but more than 2 to 3, you have nuclear atypia and you have necrosis are the criteria for sarcomas. Now, this fibroid has got blood supply. One you saw from the splenic flexure area of the peritoneum, and this is from the retroperitoneum just left to the sacral promontory. So these fibroids have to be removed after taking care of the blood supply. And if you notice the blood supply looks extremely dangerous, intimidating, because it doesn't come through muscle. It comes through peritoneum. The vessels are completely unsupported. They grow very rapidly. They're very thin-walled, so need to be handled with care. Now, each and every fibroid here had to be accounted for, put inside a bag. So we used 3 bags to get all these fibroids out. And finally, we insisted on getting a IVF conception because we couldn't wait for her to develop more fibroids. And then we had a lovely baby. Maybe now we'll think of giving her, probably doing an oophorectomy on this patient and a hysterectomy once she completes childbearing, because we don't know what will cause not growing these fibroids with the ovary in place. Now, leiomyosarcoma was thought to be a very, very rare tumor, the incidence being 1 in 10,000. The incidence currently is probably something to the tune of 1 in 480 to 1 in 1,800. These are a few of the sarcomas that we found. And it is very important to keep in mind that sarcomas are not something that are only to be read in the textbook. This is a fibroid which was observed for about 8 to 9 years before. When it started growing, she was advised a surgery, and this was a very grade 3 leiomyosarcoma. Did the surgery. When you start doing the surgery, you realize that this does not look like a fibroid. Anytime you have a fibroid like this, it will invade the planes. Normally the fibroids wouldn't, and the tissue, the texture. Now we sent 2 pieces of this for frozen section. The report came negative. So probably the frozen section is also not completely in place to detect fibroids which are atypical or sarcomatous. This is the bed. I think we've talked a lot on fibroids for a Sunday morning. Just wanted to make this thought that fibroids cannot be taken lightly. We are having a lot of number of fibroids coming. Young girls, perimenopausal women also a part of this. We used to feel that till your reproductive age, you get very few fibroids, and once you're menopausal, you don't get fibroids. But the fibroids that grow after menopause are the ones that we really need to worry about. Thank you so much. And I thank you from Sir H.N. Reliance Foundation Hospital for giving us this wonderful opportunity to talk to you all on a Sunday morning. Thank you.
Thank you very much, madam. It was a wonderful lecture because fibroid is something which comes to even a family physician day to day, and you gave a nice explanation how to tackle these fibroids. There are a few questions, madam. I'll just go through them. Madam, what is the success rate of interventional radiology in case of a large fibroid?
So, as I said, normally what happens is when you tackle a large fibroid, that means you can't wish away the fibroid immediately. The fibroid will remain as a large muscular mass which is dead, aseptic but dead, and it will attract infections. So very large fibroids probably need surgical removal. And the incidence of having a reoperation after MRI directed high focused ultrasound is to the tune of 59% in 5 years. 60% of women may need surgery within 5 years.
Another question is, do you advise histopathology in all operated fibroid cases?
110% yes, including that if there are multiple fibroids, then every fibroid also, so they have to take multiple sections, because now we've seen, earlier we were told that if there is a single fibroid rapidly growing, more vascularity, then it can be sarcoma. Today it doesn't hold. We have found sarcomatous changes in one of the multiple fibroids also. And there is no risk, preoperative risk assessment score.
Yeah. Okay, thank you very much, madam. It was really a nice lecture. And thanks a lot from IMA Mumbai branch.
Thank you. I would want to congratulate all of you for the wonderful work you all are doing. Thank you.
Thank you, madam. We now move on to our next speaker, and the next speaker is Dr. Nimit Shah. Just share his biodata. Dr. Nimit Shah is interventional cardiologist at Sir H.N. Reliance Hospital and Research Center. He is a graduate of ACPM Medical College and received MD from University of Dundee, UK. He then received Certificate of Completion of Training in Cardiology from the prestigious University of Oxford, UK. He then obtained a fellowship in cardiovascular research from UK and an advanced interventional fellowship from Royal Bournemouth Hospital, UK. He has worked in most of the reputed hospitals in UK for almost 13 years before he came back to India. He has a vast experience in both the general as well as interventional cardiology. Dr. Shah has authored 16 research international publications and around 22 conference publications. He is a proctor for IVUS, FFR, OCT, and rotablation. Over to Dr. Nimish Shah for his new and extensive topic on cardiology.
First, let me thank HN Reliance Hospital and also IMA Mumbai branch to giving me this opportunity. Again, it's always difficult to follow after a legendary like Dr. Verti. It was an excellent presentation by Dr. Verti. Fantastic pictures, fantastic videos, and I'll be following up with boring black and white angio. So just bear with me. So today I'm going to speak about tools and skills for complex PCI. So, as just to give you a brief, we all know what angioplasty is. In angioplasty, once you find there's a lesion in the artery, you pass the wire in that artery, you dilate with the balloon for the stent to go in, and then you put a stent in. Then you again dilate the stent so it sticks to the wall of the artery very well. So that is what we call it a simple angioplasty. So it's not a rocket science. But what I'm going to speak about, what are the tools and skills required for a complex angioplasty? In fact, this is just a demonstration that you have to be innovative. You have to think out of the box. Any one of y'all who would have attended angiographies or angioplasties in the cath lab, normally a doctor stands on the right side of the patient and do the procedure. Very rarely we have to use left radial artery because there's a problem on the right side. So this is me working in Bournemouth. You can see my staff from Bournemouth. So I'm standing on the left side of the patient, my back facing the patient. So this is just, you have to think out of the box and do various things to make yourself comfortable and also easy for the patient as well. So what I'm going to speak today is an entity which is known as a chip. Chip, what we define is a complex, high risk and indicated patient. What I mean is, this is because most of the patients in India who are very complex, elderly and high risk, they're either undertreated or they are not treated at all, or they are not treated properly, especially if there is a complex lesion and we don't have the skills, or the patient has a lot of comorbidity. Either they are just deemed for medical management, or because the operator cannot do the procedure, or he just decides to manage the patient medically. But these patients do benefit from the intervention, especially if you have got the tools and skills to do that. For example, a patient with comorbidity and surgical ineligibility. For example, patient might have a complex triple vessel disease, but not fit for surgeries, which would be elderly, patient with heart failure, patient with chronic obstructive airway disease, peripheral disease, renal disease, and previous CABG. Complexity, a patient might have complete total occlusion of the artery, which is always difficult to open up if the artery is blocked for a long time. If the left main artery is blocked, if there's a lesion at the bifurcation, the vein grafts, or there's tortuous and there's a lot of thrombus. So these are the complex lesions which we come across. And as far as if on top of that, if patient has poor ventricular function, if ejection fraction is low, his blood pressure is low, so this all becomes a khichdi and it's very difficult to deal with it. So you need the right skills. So normally what happens, especially even in abroad, these patients would be deemed not treatable, just manage them medically or end of life care or just palliative treatment. But now that we have various new tools and also skills, we can manage this patient symptomatically, make them better and give a good quality of life. So I'll give you, I'll show you two cases which we have done. I've done many cases, this sort of complex, and I love doing those cases. But I'll show you two cases which I would, cater to all the tools, various tools available, and what are the skills required to do these cases. So why chip in India? So in fact, we have a lot of comorbidities because of diabetes. We have more complex coronary artery disease. So complete treatment option for complex high risk and indicated patient have get a lot of interest and momentum worldwide in last several years. So, last 5 to 6 years, a lot of, even worldwide, people are taking up chip cases, which is complex, high risk, but indicated patient. This has been very vastly discussed in the international meetings like TCT and EuroPCR. In India, are we up to the challenge of treating the complex and high-risk patient? This suggests that interventionalists are systematically under-treating important patient cohorts with PCI due to risk or just an avoidance behavior, which I mentioned before. But there's a high-risk treatment paradox as well. So high-risk cases have the greatest incremental mortality benefit from the treatment, but are simultaneously are least desirable to treat based on absolute mortality. So as an operator, you have an avoidance behavior because the mortality is more. If you're taking more high risk, the more complications, more mortality, and you always worry about your reputation. Oh, this patient, this doctor, patient did this angioplasty and patient couldn't make it, or there were complications. But you have to understand that more the risk, high risk patient you take, the more the complications of mortality is going to be there. But you shouldn't shy away from that. Very important is you speak to the patient, you speak to the family, you speak to the referring physician as well, and have a multidisciplinary meeting, especially for this sort of cases. And there has to be consensus among the patient, among the caretakers, family, and also the treating physicians. So it has to be a multidisciplinary approach before you take this high-risk patient, because these treatments are expensive as well, because you're using tools, devices, which are quite costly. So the chip operators, there are creed, which says the indication for the case do not change just because the lesion is harder to treat. Fair enough, because some else might not able to treat, but I know I can treat it. That's the operator treat. And there's a cardiologist creed, which like non-invasive cardiology would say, it doesn't mean that if you can do something, you have to do something. Fair enough. For example, just because I can open up the artery, I shouldn't be opening up the artery unless I prove by some physiological test this is going to benefit the patient. I shouldn't be doing angioplasty just for the heck of doing an angioplasty. I have to prove that this is going to make him symptomatically better, probably improve the left ventricular systolic function. That is when I should take these high-risk operative cases. To select appropriate cases with a strong indication for revascularization, communicate and document the added risk of those procedures, as I already mentioned. And this is very important medico-legally as well, because you're taking this high-risk complex patient, a lot of money involved. So your documentations, communicating the risk and benefit of the procedure is very important. And this is what I was trained in UK as well. The documentation was the key thing. Again, do not condemn your patient to medical therapy if you do not feel you have the tools or time to offer an optimal chip procedure. Refer your patient to a center with chip expertise. This is what happens abroad. Like if there's a small center, they cannot do it, they would refer you to a bigger center. Unfortunately, it doesn't happen in India quite often, because we love our patient. We don't want the patient to be referred to someone else because of the ego or because of the, the way the work works here. So, but we should care for the patient. And if we think that someone else can do this procedure, we should refer this patient. So I won't bore you with this because this is quite technical. These are type of lesion which I've already mentioned, either left main or artery is completely blocked. There's a lot of calcium, which you might require a lot of devices. If there are long bifurcation lesion, patient is hemodynamically unstable and a lot of comorbidities. So what we require? What are the toolbox and proficiencies required for a chip operator? We should have range of wires to cross that lesion, high profile crossing and cutting balloons. If there's a calcium fibrosis, we should be able to break that. Good support catheters. We should have imaging tools like IVIS, OCT, FFR, and of course, rota ablation, where we have to drill the calcium. And there's new thing which is coming up. I have used quite a lot in UK. I'll show in one of my cases as well, which is a laser angioplasty, and I'll tell you where it works, and so forth and so forth. Let me go through the case here. So this is a 73-year-old male, diabetes, hypertension, acute on chronic CRF, peripheral vascular disease, came with an acute admission with non-STEMI and congestive heart failure, had a severe LV dysfunction, if EF of just 15%, 1.5. So initial strategy, as you would rightly say, oh, he's a 73-year-old, he's got a lot of comorbidities, pump ejection fraction just 15%, just leave him alone, let him die peacefully, and probably a palliative treatment. So initially strategy of medical therapy by local team, but in spite of that, he kept on having refractory angina, decubitus angina. That means whenever he lied down, he used to get chest heaviness. He was on Lasix infusion, nitrate infusion, still getting ongoing symptoms. even after 6 weeks, so he was in that center for 6 weeks in UK. This was the case I did in UK. For pharmacokinetics failing to control the symptoms. Hence, he was transferred to our center. And this is an angiogram, which was done via radial artery. The right artery, there is some disease, but not much. This is the left-sided artery. The circumflex looks fine. So here it is. So this is a LAD, which is, you would know, supplies more than 50% blood supply to the heart. It's got a quite long calcified. Here it's a long, so this is a normal artery. This is completely calcified, long lesion up to here, like a subtotally occluded. So we do something scoring, which is known as a syntax score, to look how complex this is. So anything above 22 is complex. This is 31. Euroscore 236, this to again to look at how complex the patient is for surgery. So high Euroscore, the patient was high risk for CABG as well. I would appreciate the pumping action was just 15%. So what was the clinical decision making? So again, so we didn't do anything on the table. We took the patient off the table and then we had a multidisciplinary meeting. So is this a chip case? That means, is this complex? Yes. Is this high risk? Yes. Is the procedure indicated? Yes. Should I take this patient off the table and do ad hoc or stage it? So we did the right thing and we should do all this unless the patient is really bad, acute emergency. Otherwise, this sort of patient, you take them off the table, discuss with them, discuss with the family, all the caretakers, and then schedule them in a day or two. Other thing, should I do case at all? Yes. 6 weeks of pharmacotherapy, patient is difficult to get the patient off the hospital, off the discharge. So there was strong indication to do the patient. Should I do this vessel? Which vessel should I do? So this is 73-year-old. We need to do an LED. Forget about the circumflex, forget about the RCA. Just make him symptomatically better. So it was just planned to do a single vessel. There's calcium everywhere and subtotally occlusion of the LED, and there's a bifurcation as well. There's RCA is completely blocked, but small vessel. So there was a lot of complexity within the vessel as well. It wasn't a straightforward procedure as well. Then you have to think which devices would you use, what technique would you use. So that takes a lot of time and you should manage it very nicely. So then should I use any intravascular imaging like IVUS or OCT? Do I need mechanical support in this case like Impella or intra-aortic balloon pump? Or when everything is done, like PCI completed, how would I follow up the patient? What would be the pharmacotherapy? Would he need an exercise test? Would he need a control angiogram? So you should have everything in your mind, everything very well organized. Then you can plan and treat the patient optimally well. So we had an MDT discussion. Seen by surgeon, he was surgically turned down. He was deemed very high risk PCI for LAD. There was extensive calcification. So we decided we'll have to do rotational atherectomy, which is known as rotablation. Would need a mechanical support, intra-aortic balloon pump or Impella. Intra-aortic balloon pump increases the cardiac output by just 0.5 ml liter for 0.5 ml, but Impella increases the output by 2.5 liter. So we elected that we would use Impella. Impella is a special, it's like an artificial pump, which we use even like not like a bypass, but it's an artificial pump which pumps the blood from the aorta into the from the left ventricle into the aorta and increase the coronary flow. So we did the peripheral CT because Impella requires good large caliber cerebral artery. This is an Impella which causes which gives 2.5 liter per minute cardiac output independent of cardiac function. It is a continuous flow. It would reduce the LV diastolic pressure, increase the aortic pressure, and helps in LV unloading. This is, we started from the femoral artery. You can see it's very heavily calcified. The sheath wouldn't go up. If over here, we are trying to push the sheath, but it is not going up. So even the start of the procedure, we were having problem even before reaching the heart, even in the legs. So we had to dilate this, the peripheral artery. And then we were able to advance the sheath. This is an Impella. You will go slowly. If you see this, this is an Impella on the right side of the panel. This is the Impella on the right side of the panel. It's going along the arch of aorta. You'll see it's very heavily calcified aortic arch. And this is a wire into the left ventricle. So this sits into the left ventricle very nicely. So this is an Impella over here. You could see this. This is a motor which helps, this draws the blood from the left ventricle and throws it into the aorta. So this is started. We are trying to wire this artery. Very difficult to wire. Wire wouldn't pass. So we had to use a support which is known as the fine cross support. But even after passing the wire, the fine cross, this is we have to use a fine cross so we can exchange it for the rota wire. But the even smallest fine cross wouldn't cross the lesion. It was such a hard lesion that fine cross wouldn't cross. So what we did is, so there's a thing which is known as laser angioplasty. You all would have not heard of this, but I've been using this UK for quite a long. And the good news is that this is now commercially launched in India. In fact, there was a trial done in India, and I was one of the proctor for Bangalore, where I went and did 5 cases there. And we have now gotten approval from the Indian government DCGI. And hopefully, and if we are lucky, we might have the first laser machine in HN Reliance Hospital, Mumbai. So, and I have published this paper. I was one of the author, where laser is used in this sort of situation where balloon doesn't cross or doesn't dilate. So we can create a channel by delivering the laser energy through the catheter. It works by a different mechanism. I won't go into the detail here. So once we did the laser, then it was easy for the wire to go down, and then we were able to do rota ablation. So if you see on the right side panel, there's a black dot which is moving. So that's a diamond crystal. And we drill the calcium so that balloon or the stent would be able to go. So we try and break the calcium. So we create a room. So again, this requires a lot of technical skills and challenges over here. So the good news, the lucky we were, because of the impella, when we did the rota ablation, he was almost peri-arrest. The blood pressure, because there's a lot of device going on, there's a lot of handling of the artery, decrease in the flow while we pushing the devices within the artery, the blood pressure had gone down to 40-60 systolic. Because impella was acting as an artificial heart, where it was continuously pumping the blood from the left ventricle into the aorta, we could do this procedure. If impella wasn't there, acting as a pump, this patient would have arrested and would have lost when we were doing a rota ablation. So this is where the impella helped us. And as soon as the rota ablation was complete, his blood pressure was 120 systolic. And then it was straightforward. We dilated the artery, and this is the final picture. You can see so the flow is brilliant. The branches have opened up, a lot of blush. So this take-home messages for this case was, in the presence of cerebral LV dysfunction, which is high risk but complex PCI, is more safely achievable with mechanical support devices such as impella. Without the support of impella device, patient would have not tolerated the high-risk rota ablation. Despite adequate guide wire support, this occlusion could not be crossed even with a fine cross microcatheter, Corsair, or even a low-profile balloon. Hence, we use ELCA. ELCA is excimer laser coronary angioplasty catheter. So we had to use laser, which helped us to create a channel and pass the microcatheter and eventually rota ablation. If we didn't have an ELCA or laser, we would have to stop that procedure there and there. And then, of course, we had a rota ablation, which helped us to deploy the stents. So in the end, he had a good angiography and clinical outcome with improved LV function and successful discharge of the patient from the hospital after 1 week. So this was in UK, but what are we doing in India? So let me give you a replica of the case in India. Of course, limited tools available, but the skills remain the same. So again, in India, this is 82-year-old male, diabetic, hypertensive. He presented with fever in one of the hospitals in central Mumbai, suburb. He had normal ECG and echo. After a few days, he developed acute breathlessness requiring intubation and inotropes. There were new ECG changes, and his ejection fraction had dropped to 30%. That means he had an MI, myocardial infarction, while was he in the hospital. His diagnostic angiogram was done. He had a very tight left main disease. His circumference was also blocked, and there was a very significant lesion in the LAD, and LAD had a quite acute bend. So again, a very high-risk patient, very complex. This angiography CD was sent to me while I was in Mumbai. I went to the CD. The patient this was done in the morning, and I was asked to rush to New Mumbai, the Reliance Hospital over there, to go and do this procedure in midnight. So I went there. We did the first picture. This is very critical left main. And he's got critical left main. The origin of the LAD and mid LAD is critical. The circumflex ostium is critical as well. So what we did is, so again, right also had a very significant lesion, but I wanted to do the left main to LAD and circumflex, so at least we can salvage this patient. We did not have impla, but we did have intra-aortic balloon pump here, ejection fraction of 30%. So we used intra-aortic balloon pump. We put a temporary pacing wire, and the plan was to do a rota ablation to the left main to LAD and then to the circumflex artery. So we wired the artery. Then we tried to do a fine cross. The fine cross wouldn't go in. Same like previous. Luckily here we didn't require the rota ablation. See, I'm trying to push my device, and this is pushing away the catheter. Eventually, I did manage to get the rota wire down, and then we did the rota ablation. So once the rota ablation, so this is on the right side panel, there's a burr. We adjust the guide. At every time I tried to push any devices inside, the blood pressure would drop. So we had to stop, get the NORAD up, get the blood pressure up, then again restart. So again, it was technically very challenging, again, very high risk. Had a lot of discussion with the family. There were few family members who had flown from US for the patient, the grandsons, and also I had to explain to them everything. There were high risk that patient would have succumbed on the table. So we took this high risk patient. So once I had done a rota ablation from the left main to LAD, we did get a flow. So then I had to do a rota ablation of the circumflex. So we then changed so I did rota ablation only up to the proximal LAD because there was a quite deep, acute bend in the mid LAD. And if my fear was if I tried to do a rota ablation because I was using a big burr, the artery might just burst open and he would have just died on the table. So I was just trying to do the proximal part and wish my luck, try a small balloon and do the middle part. So once I had done the proximal part, then I wired the circumflex artery, did a rota ablation of the circumflex artery. So once I did the rota ablation of the circumflex artery, what happened is patient again started developing hypotension. The reason being is his LAD blocked off. Because there was a plaque shift or the thrombus shift, his LAD completely blocked off. I'll show you here. See here, the right side panel down. So LAD had completely blocked off. So I had to again rewire it quickly, balloon dilate, and establish the flow. I couldn't pass the balloon within that mid portion. Everything was coming back. Then I had to take a risk, use a smaller rota ablation wire. Spoke to the family again. I stopped the procedure. Spoke to the family again. See, I have done the rota ablation of the proximal LAD, also circumflex. There is some flow. His hemodynamics are better, but I need to do this middle part. There's a chances that he might have a perforation. So again, took a consent, verbal consent, and went ahead. So luckily, I was able to negotiate the mid part as well with very cautious, slow rota ablation. With the support of the intra-aortic balloon pump, I was able to do a rota ablation. It was a standard procedure where I deployed the stent balloon. I'll show you the final picture. So these are the balloon dilatation pictures. This is a long stent going into the LAD over here, from the mid to the proximal part. Then from the mid part to the ostium of the left main across the circumflex. Balloon dilatation of the LAD was done. Then I had to cross through the stent studs, go into the circumflex. See the wire here, so it's crossed over here. Then get a stent into the circumflex, put a balloon into the LAD, so that balloon prevents the stents coming back into the left main and blocking the LAD. So this is bifurcation left main, again technically very challenging. So once done, so this is the flow. So once so good left main, establish the flow into the LAD and circumflex, patient hemodynamically improved. So patient stayed on the patient came off inotropes in next 24 to 48 hours. See, this is the final picture. Beautiful result here. A lot of branches coming out, good blush into the arteries. Unfortunately, patient had a GI bleed over there after 3 to 4 days. He did not improve from his pneumonia. Though hemodynamics was better, cardiac function had improved, ejection fraction, but unfortunately he succumbed after 15 days because of respiratory issues. So that was, in spite of doing so much hard work, me going all the way there, 12, I finished at 5 o'clock in the morning. This was 5 hours procedure. but unfortunately, patient died after 15 days because of non-cardiac issues. So, in summary, thoughtful and reasonable clinical indication for PCI therapy. So, clinician versus proceduralist has to be taken into the mind. Command for advanced PCI. So, you should be well trained, should have good case experience, embrace collective wisdom. So, speak to your surgeon, speak to the anesthetist, respect the opinion as well, and familiarity with all the new toys, rotablation, laser, special catheters. You should be familiar with the tools. Judicious use of intravascular imaging and physiological lesion assessment should be important, and appropriate use of mechanical circulatory support like intra-aortic balloon pump or impella should be taken, and commitment to evidence-based validation of new devices and therapy approaches. So you have to make sure that's evidence-based, there is a good research done on the devices. You shouldn't use devices just because they are available. There should be a scientific backing for that. Thank you. I'll take any questions if available. Dr. Anil?
So there are no questions as such. I think they must have understood you totally.
Or understood nothing.
Okay. Thank you very much, Nimisha sir. It's always nice to hear you because I have heard you before also many times. Yeah. Thank you. Thank you. Friends, now we move on to our next speaker, and that is Dr. Ashay Shingre. I'll just share his biodata. Dr. Ashay Shingre is consultant nephrology, Department of Nephrology, Jaslok Hospital and Research Center. He did his MBBS from LTMMC and Sion Hospital, followed by MD in General Medicine from St. GS Medical College and KM Hospital, Mumbai. He then pursued DNB Nephrology from Jaslok Hospital and Research Center. He also did certificate program in clinical nephrology, nephropathology by the International Society of Nephrology. He has several publications to his credit. He is actively involved in many clinical research trials. His areas of interest are clinical nephrology, hemodialysis, peritoneal dialysis, critical care nephrology, and renal transplant. Today he is going to update us on when to go for kidney transplantation. Over to Dr. Ashay Shingre.
Thank you, sir. Thank you for the introduction. Thank you, sir. Good morning, everyone. So, at the outset, I would like to thank all the IMA office bearers for giving me this opportunity. And I would also like to congratulate the IMA for all the wonderful work that they have been doing. Today, I'll be speaking about when to go for kidney transplantation. So, let's just review in short functions of the kidney, removal of the waste products, so the making urine, but apart from that, there are a lot of other functions: fluid balance, maintaining acid-base electrolyte balance, blood pressure control, erythropoietin production, and maintaining hemoglobin levels and vitamin D activation. So what is the incidence and prevalence of end-stage kidney disease? Now with improvements in dialysis technologies and as well as conservative management of chronic kidney disease, the incidence hasn't changed much, but the prevalence has definitely increased. At the longevity of patients with chronic kidney disease is increasing. So over years now, the prevalence of kidney disease has been going up and up, whereas the incidence has remained more or less the same. Possible symptoms of kidney disease. So the patient will initially approach his primary care physician for the symptoms, and the symptoms may not really be specific. The symptoms may be in the form of reduced amount of urine, some swelling in the feet, or some breathlessness. The patient may complain of drowsiness, fatigue, nausea. In advanced kidney disease now, with the retention of uremic product, the patient may develop seizures or coma. Now, many of these symptoms are non-specific, and many patients may be asymptomatic during the early stage of kidney disease. Hence, these symptoms may not be diagnosed as the patient having an underlying kidney disease. The patient may be unaware until advanced stage, and they may visit their primary care physician with this symptom. The primary care physician will then evaluate, and on creatinine testing, urine routine testing, then the patient may get diagnosed with a kidney disease. So the initial treatment, of course, in chronic kidney disease, in the initial stages is conservative management. But ultimately, when the patient lands up in end-stage kidney disease, when there is a lot of accumulation of uremic toxins, then we will have to consider the options for his end-stage kidney disease. So the options are between renal replacement therapy and supportive care. So in renal replacement therapy, we have three options: either to go ahead with a kidney transplant, or to do hemodialysis or peritoneal dialysis. Supportive care is generally for very elderly patients with a lot of comorbidities where they won't be opting for renal replacement therapy. They're just supportive care or end of life care may be chosen as an option. Um, Prior to this, choosing the renal replacement therapy, a lot of planning has to be done. This has to be discussed with the patient and the family members so that they have a clear idea what will be the treatment modality that they will choose. So it is important to discuss the available options, plan in advance whether the patient wants to go ahead with the transplant or the patient wants to continue on dialysis. It is recommended not to delay this therapy. Many times patients don't come up with a decision and they just keep on monitoring creatinine and ultimately they'll end up in an emergency and then they get admitted in the ICU. So it is important that we discuss this and plan out that whatever modality is chosen, we plan for this in advance. So avoid life-threatening complications and emergencies. Now this is about the survival probability in dialysis patient. So this is over every 5 years. So what has happened is gradually the survival probability is slowly getting better, but still the survival probability at the end of about 5 years is still 50% or less than 50%. So over years, although there are improvement in dialysis technologies, at the end of 5 years, only about 50% of patients survive while continuing with hemodialysis. This is dialysis survival compared to some common cancers in men as well as women. So what we see here is survival probability for breast cancer, prostate cancer, and colorectal cancer. So in previous years from 97 to 2001, 2002 to 6, and then 7 to 11. So for breast cancer, prostate cancer, the survival probability has gradually gone up. For colorectal cancer, also the survival probability is better. But for dialysis, the survival probability is remained at about 30%. So in all these eras, the survival probability of dialysis patients is lesser than that of breast cancer and colorectal cancer. These patients maybe they do better than lung cancer and pancreatic cancer in survival, but their survival is definitely less than that of breast cancer and colorectal cancer. This is all-cause mortality in dialysis as well as transplant population. So if you see over the years, now this is for deaths in per 1,000 patient years. So for dialysis patients, the deaths range between 250 to 200, and over the years the deaths have come down slightly less than 200. But for the transplant patients, the deaths are less. So 50, and they have now come down to around 40 deaths per 1,000 patient years. So definitely the death rate is less in transplant patients and as compared to the dialysis patient. And so in terms of treatment options for end-stage kidney disease, among these three treatment options, definitely the best treatment option in terms of quality of life and survival probability is transplant as compared to hemodialysis as well as peritoneal dialysis. So now we'll go to the little what, when, and who of kidney transplantation. So what is kidney transplant? So transplant kidney is taken from a donor, and it is then surgically by surgical procedure. It is anastomosed to the vessels, and it is placed in the iliac fossa. The deceased kidneys remain at their native position. A lot of patients and relatives have the question that are these deceased kidneys removed? No, they are not removed. They are just left in place. They are not touched. Only in certain circumstances, like if the deceased kidney is giving rise to recurrent urinary infections, any abscess over there, then they have to be removed. Otherwise, they are not touched in the transplant surgery. So, surgical procedure: the transplanted kidney is placed in the right or left lower quadrant of the abdomen. It is extraperitoneal surgery, and on examination, the transplant kidney can be easily palpated. So, why kidney transplant? So, it is most effective therapy for end-stage kidney disease compared to hemodialysis and peritoneal dialysis. It definitely offers a better long-term survival, and it gives an improved quality of life as compared to dialysis. What are the benefits and risks of kidney transplantation? Benefits: so significantly reduced risk of mortality. Life expectancy can triple actually. So as compared to the hemodialysis and peritoneal dialysis, there is reduced risk of heart disease, stroke, and cardiac failures after a kidney transplantation. Definitely, the quality of life is improved, and the patient becomes more independent. He is not attached to a dialysis center where he has to go 3 times a week and do hemodialysis. So he's more likely to stay employed because of his independence, because he's able to travel also. On risks of kidney transplantation. So there are definitely some risks attached, acute rejection or failure. But with the current immunosuppression medication regimens which are available, this risk has definitely come down. And then there are side effects because of the medications which are given. So the side effects include infection. As the immunity, as the patient becomes immunosuppressed with these medications, there are chances of infection, malignancies. There is increased risk of glucose intolerance, hypertension, as well as dyslipidemia. And then graft loss over time if proper care of the graft is not taken. But the benefits far outweigh the risks in these patients, and hence it still remains transplant still remains the better treatment option for end-stage kidney disease. Now, how do dialysis and transplant compare? So dialysis can only do 10 to 15% of what a normal kidney does. So typically in dialysis, the patient visits a dialysis center 2 or 3 times a week, and it's a typical 4 hour session where where all the uremic toxins are removed from the blood. But it is not a continuous therapy. It is only done 2 or 3 times a week, and that too 4 hour session. Whereas a transplant, it can do about 50 to 85% what a normal kidney does. Now, transplant kidney will keep on working 24/7 and keep on removing all these toxins continuously. Hence, it definitely does more work as compared to dialysis. People on dialysis have to follow a rigid diet plan. In transplant, the diet is little more liberal. Patients definitely have to take care of properly cooked food and healthy food, as well as it should be clean water. But definitely they can be more liberal with their food and water as compared to dialysis. People on dialysis typically have low energy levels, whereas people who get a transplant often have more energy than patients on dialysis, and they can go back to work. Now, survival on dialysis versus transplants. So the at the end of 1 year, about the survival in transplant is more than 95%, but the survival on dialysis is about 80%. And as the years progress, the survival on dialysis goes lesser and lesser. So at the end of 5 years, less than 50% patients are survive while continuing on dialysis, whereas the transplant survival is definitely better. What about cost of dialysis versus transplant? So in the first year, transplant definitely costs more because of the surgical procedure, but in subsequent years, the cost of transplantation is only just the medications, and hence the cost becomes less. Whereas dialysis in the first year may not look as costly, but the cost is cumulative. Every time the patient comes for dialysis, patient has to pay for dialysis and all the consumables they are used. So cumulatively, the cost of dialysis over years goes on increasing. So if you see here, in the first year, the dialysis cost is less as compared to transplant, but the cumulative cost over years, transplant cost definitely remains less. The cost of dialysis versus transplant again, in center dialysis, whereas transplant. First year and sorry. So in center dialysis, the cost is definitely more, and the transplant cost is less. So who can undergo kidney transplantation? So there are no absolute age limits for kidney transplantation. Absolute contraindications. So absolute contraindications will be active infection, active malignancy, severe respiratory conditions, ischemic heart disease or peripheral vascular disease, non-compliance, hepatitis, and HIV are no longer contraindications. So patients with chronic infections which are under control definitely can undergo kidney transplantation. Pre-transplant issues to consider. So cardiovascular disease, if whether the patient has underlying cardiovascular disease. So it is better that patients with diabetes undergo angiography initially to evaluate for this cardiovascular disease. If they have ISD, then it is better to tackle this issue first prior to going ahead with transplant. This is important because the patient will be on antiplatelets, and then going ahead with the if the patient undergoes transplant and then later on is detected with ISD, then we have to use contrast, which can actually hamper the graft function. Infection risk, all the infections have to be ruled out in patients who will be undergoing kidney transplant. They need to undergo immunization also, so as to prevent infections in post-transplant period. Malignancy risk, psychosocial factors have to be evaluated. Immune function, physical function, whether the patient has disabilities, cognition, and patient's expectations and the quality of life. So based on the types of donor, what are the types of transplant? So living donor kidney transplant and deceased donor kidney transplant. Living donor, typically living related donors, so first degree relatives donate the kidneys. And there is another modality which is kidney paired exchange. We'll see little in detail about kidney paired exchange later. This is donor is either a brain dead donor or cardiac dead donor. So this is also commonly called as a cadaveric donor. A brain death donor is the patient is with a beating heart, so there's only brainstem death, but the heart is functioning. And cardiac death in India, actually by now only brain death donation is allowed, cardiac death donation is not allowed. So in terms of living donor, who can donate? So close relatives of the recipient. So parents, siblings, children, spouse, grandparents, and grandchildren can donate. In our setting, actually, the commonest related donor is either parent or spouse. And in terms of spouse, there are more wives who give kidneys to their husband than husband giving kidneys to their wife. Or then parents are the commonest donors. In case if these relatives are not fit due to some medical condition, then other extended family members are allowed, where cousins, uncle, aunts may be considered. And age should be obviously 18 years and above. Pre-transplant donor evaluation. Now it is important to evaluate the donor thoroughly so that the donor does not land up in a problem later on. So a lot of investigations are done for the donor: history, physical examination, blood grouping, all the urine, renal function, liver function, and hemograms, urine culture. All the viral markers have to be checked. The donors undergo a renal scan to check what is the function of the individual kidney and the 6 hours urinary creatinine clearance. A lot of imaging studies, chest X-ray, ECG, echo, sonography, renal angiography to delineate the renal vessels. And then the last step would be a HLA typing and to look for donor-specific antibodies. So this is to look whether the recipient has any antibodies against these donors which are preformed. The donor also undergoes a psychiatric evaluation. The psychiatrist evaluates whether the donor is fit to donate the kidneys, whether it is a informed decision and a self decision, or whether the donor is being pressurized or has taken a decision without any without knowing the consequences. Renal donors, commonest disqualifications. So commonest would be presence of comorbidities in the donor. So hypertension, diabetes, ischemic heart disease, these would actually disqualify the donors. Having a low GFR, severe systemic disease, or a genetic renal disease, or a positive tissue cross-line. This may be a relative contraindication. Now, the donors have a question that post nephrectomy, what will be my life, and what will I have to do? So post nephrectomy, actually, the donor is as normal as anybody, and any incidental disease that he may suffer from subsequently must be treated as one would treat a non-donor person. So if the donor does not have these comorbidities and goes and is willing to go ahead, then he can donate the kidney. No dosage changes are required. So if the donor develops the illness later, he has to take regular medications as treated. Antibiotic, no changes in the doses required. Only a precaution with the painkillers is required. So the donor has to avoid NSAID kind of painkiller medications. Authorization for transplant is required. So there is a hospital authorization committee which reviews, sanctions. They take an interview of the donor, of the recipient, and the next of kin of both the family members, and only after that the authorization is allowed. There is a state authorization committee. So in certain situations, state authorization committee approval is also needed. This would typically be in case of extended family members donating or a foreign patient. For foreign nationals, there are other paperwork which are required: passport, clearance from concerned authority, embassy, and documents supporting the relationship are required, including affiliation. When to go in for kidney transplant? So based on transplant preemptive, living donor, non-preemptive, and deceased donor kidney transplant. So the determining factors are donor availability, blood group status of the donor and the recipient, the antibody compatibility, and the recipient status, and definitely finances. So preemptive transplant, what are the benefits? Transplant before dialysis started, this is preemptive transplant. So if the patient is detected with a chronic kidney disease, then before landing up on dialysis, they prepare themselves for transplant, they plan everything, they get the approval, and then when the time comes that the patient has to start RIT, the patient directly goes ahead with the transplant. So the benefits are decreased rejection rates by 25%, improved graft survival, improved patient survival, less chances of delayed graft function, decreased overall hospitalization. It avoids the need for dialysis access placement, which has its own issues of infections and thrombosis. Avoid dialysis complications like infections, blood transfusions, cardiac dysfunction, high blood pressure, need for central line. It maintains the recipient employment, and definitely it is cost saving because all the dialysis related costs are saved. So preemptive transplant is more beneficial. Blood group compatibility based on the um, blood group of the donor and recipient, they can be ABO compatible pair or ABO incompatible pair. So if the if the donor and recipient are ABO incompatible pair, the options are ABO incompatible kidney transplant, pair exchange, or disease donation. We'll see about these options later. So blood group compatibility, O group can give to anyone. So if you have blood group O, you can donate to any of these members. And AB can receive kidney from anyone. So AB is, this is just like blood transfusion. AB is universal recipient, so they can take a kidney from anyone, and O can donate to anyone. If there is no match in this, so like if the donor is A and the recipient is B or vice versa, then it becomes a ABO incompatible kidney transplant. Or if the recipient is O and the donor is A, then it becomes a ABO incompatible kidney transplant. So ABO incompatible kidney transplant, can it take place? Yes, it can take place. We have protocols in place to do ABO incompatible kidney transplant. Over the years, this has the strategies have evolved. Initially, it used to be a surgical procedure of splenectomy, but now rituximab is available, and then we have to remove these anti-ABO antibodies with plasmapheresis and with plasma exchange, and we can use immunoadsorption columns and IV immunoglobulins. So kidney paired donation, this can be referred to as swap transplant in common terms, or kidney paired exchange. So kidney paired donation is where there are two or more pairs who have incompatible blood groups. Then with a paired exchange, they can be matched as made into compatible matches, and they can undergo simultaneous donation. So this is an example. So this is a donor recipient pair where the donor is A and the recipient is B. This is a ABO incompatible pair. The other pair where the donor is B and the recipient is A. Now this donor 1 will donate to recipient 2 and donor 2 will recipient to recipient B. So they become a ABO compatible pair, A to A and B to B. This is a kidney pair transplant between two pairs. Kidney pair transplant in between three pairs. So A will donate to the second one AB to AB, and this O to O. So this is how kidney pair transplant with three pairs can be done. What is the need for kidney pair transplant? In case of incompatible pairs, they can be matched into compatible pairs, but difficult to transplant pairs for increasing the donor pool. Uh, in case of ABO incompatible, desensitization is costly, and then instead of waiting for deceased donor kidney transplant or cadaver transplant, patients can go under a KPD. Indications will be blood group incompatibility and presence of antibody. Advantages are again less cost compared to the ABO incompatible kidney transplant. Outcomes are better, and it is a mutually beneficial exchange, both the pairs exchange, but disadvantages more actually mismatches. Now, for ABO incompatible kidney transplant, actually at Jaslok Hospital, we do more than 100 transplants per year, and 25% of our transplants are about ABO incompatible kidney transplant. So it is done quite commonly. Coming next to the deceased donor or cadaver transplant. Cadaver transplant is after brain death, and this is a beating heart, or after cardiac death. Cardiac death is not allowed in India. So brain death is irreversible loss of consciousness. This is unlike coma where consciousness can be regained, but in case of brain death, this is irreversible. So loss of brainstem reflexes, no respiration, and a flat EEG. So the brain death committee has to examine the patient and then certify that this is brain death. There should be no other obvious cause of coma, such as for no other cause for coma, such as sedation, use of sedative medications, hypothyroidism, hypothermia, poisoning. All this has to be ruled out when the patient is certified that it's brain death, and if the relatives are willing to proceed with organ donation, then organ harvesting is done from such patient. Main causes are trauma, so road traffic accidents and brain hemorrhage. What about rejection after kidney transplant? Yes, the body's immune system recognizes this as foreign and attacks to get rid of it. The process is called rejection. And this is a response of the body's immune system. Rejection needs to be prevented, and the patient has to take immunosuppressant medications for that. With the current era of immunosuppression medications, so 1 year graft patient survival and graft survival is more than 95%. Immunosuppression. So in the initial phase of transplant, we have to use higher dose of certain specific immunosuppression agents, which are known as induction agents, and then there is a maintenance immunosuppression. So induction agents which are used are anti-thymocyte globulin or basiliximab, and maintenance immunosuppression is usually triple regimens: steroid, tacrolimus or cyclosporin, mycophenolate, and others are sirolimus or everolimus. How long one has to take these transplant medications? Lifelong. The patient has to be prepared that they have to take medications for lifelong. This is to avoid rejection. Rejections can occur even years later, particularly if the medication is stopped. Intolerance induction techniques are still in the realm of future, but they have not yet been developed. And dosage of the medications is reduced at the risk of rejection. Listen to follow up. Each visit, the patient has to do investigations. Weight, BP, is monitored. Dose adjustment is done. We have to look for side effect of the immunosuppressant medications like post-transplant diabetes, infections, cardiovascular risk, avascular necrosis. Patients have to wear a mask. So this was even before COVID-19 era. Avoid crowded places. Food, hygienic food, properly cooked food, boiled and cooled water. They have to take care with non-cooked food like salads. Non-vegetarian food, yes, definitely patients can have. Patients can actually marry and they can have children after transplant. In fact, after transplant, the prospects of having children become better. Infertility issues are solved after transplant. Now, logistics of transplant. So, drug supply. Patients should keep a appropriate quantity of drugs with them. There should be no interruption at any cost, and they should not miss their medications. Otherwise, they'll end up with rejection. Patient is this is not just another patient in the queue, but the life virtually depends on these medications. Bioavailability of these medications will vary with brand formulations, and they may have a narrow therapeutic window. So, in summary, actually, kidney transplant it is the best treatment for patients with end-stage kidney disease. Kidney transplant saves lives, improves quality of life, and saves cost. Living kidney donation is safe and provides better outcomes. And in terms of living kidney transplant versus deceased donor kidney transplant, living kidney transplant is better. And preemptive transplant, that is before the start of dialysis, this is the best option in terms of kidney transplant. During the COVID-19 era, actually the transplant programs had a glitch, but and we had to our transplant patients had to face trouble. So these are just some of the publications that we had. So our transplant patients had developed COVID-19, but they had a very good outcome, and this we published in the American Journal of Transplantation. This was again in the American Society of Nephrology conference that we published from Just Look Hospital. One of our patients actually had COVID-19, very severe COVID-19 pneumonia. He recovered from it and later underwent ABO incompatible kidney transplant, and this was presented at Asian Transplantation Week. This was all under the guidance of Dr. Bahadur. He is the director of nephrology at Just Look Hospital. Thank you all. Once again, I would like to thank IMA and Sanofi for giving me this opportunity. Thank you. Can I answer the questions in I think there are some questions in the chat box. So one question is, how long in months or years does it take to be issued a deceased donor transplant after patient makes an application? So the patients have to apply to the zonal transplant coordination committee, but the waiting list is very long since we do not have although the deceased donor kidney transplant rate is improving, but the list is long and typically about 3 to 5 years. So the patients can take about 3 to 5 years before they receive a call for deceased donor kidney transplant. O blood group list is the longest. Instead of that, if they have a living donor in the family, they can immediately undergo a transplant. Within 1 month, they can do the approval and go ahead with the transplant. So rather than waiting 5 years on dialysis and then undergoing a cadaver transplant, it is better if there is a living donor in the family. Another question is, transplant kidney reaches late, so ischemic kidney, how many hours one should wait so that kidneys function well? So at the time of organ retrieval, actually the kidneys are perfused with cold perfusion fluid and then they are kept in ice. So the lower this the lower the time that they are kept in ice, the better the outcomes. But kidneys can be kept in this perfusion fluid for 6 hours or even 12 hours. So kidneys have been used for at the end of 6 hours, 8 hours, 12 hours till the surgery gets over. Now there are machine perfusions also available where a machine will keep on perfusing the kidneys removed from the body, kept at a machine, and the machine will keep on moving certain perfusion solutions into the renal artery and they'll come out via renal vein. So we can preserve the kidneys for a longer duration. Will post-transplant immunosuppression affect immune response in case of future vaccinations like H1N1 and COVID vaccine? So live vaccines after transplant is a strict no. So what we do is we typically immunize the patients before transplantation with live vaccines. Dead vaccines, component vaccines, yes, they can be used after transplant. So in terms of H1N1, so whatever quadrivalent influenza vaccine is available, yearly we ask our transplant patients to take those vaccines, but no live vaccines. So hepatitis B is okay, H1N1 is again okay, pneumococcal is okay. So, but no live vaccines after transplantation.
Yeah, yeah, you can.
Okay, very good morning to all. I sincerely thank to IMA, Haji Ali and Entas for giving me this opportunity. Today I'll be discussing early prostate cancer and its management, whether to go ahead with a robotic surgery or a radio surgery. That's we call as the SBRT. Am I audible to all? Hello, I hope I'm audible to all.
Yes, yes.
Yeah, here I'm here my disclosure. I sincerely thank Dr. Vesperni and Dr. Amar Kishan from the Canada for because some of my slides are based on their lecture also. In next half an hour, we will be discussing in the basic overview for prostate cancer and the various risk groups of the prostatic cancer patient and their treatment options and related common side effects. And since I'm a radiation oncologist, I'll be talking more about the role of a radiation in prostatic cancer, a particularly newer technique that is a radiosurgery, that is SBRT. And then we'll see high level of evidence which support the SBRT. And then if time permits, we can see how actually we do the SBRT in a radiation oncology department. Just to summarize the disease burden, earlier the prostatic cancer incidence was ranked at the first, but since the guidelines for the screening in the Western, they have changed in 2018, now the incidence has gone down to up to third rank, but still it is contributing more than 12 lakh cases every year worldwide. And that is coming around to a total 7% of total cancer diagnosed every year. And worldwide, if you see the death rate, it's on the 8th rank, contributing around 3.5 lakh cases every year. And if you consider this scenario with the Indian scenario, the incidence is little bit on a lower side as compared to the worldwide, but still it is contributing towards more than 25,000 every year new cases are diagnosed. But the most worrisome part in Indian counterpart is look at the death. There are around 25,000 cases are yearly diagnosed. At the same time, around 17,000 patients deaths are reported every year in the India. When the prostate cancer is not spread to the lymph nodes or any metastatic site like a bone, lung, or liver, then we group all the prostatic patients into 5 risk groups based on several parameters. The number one parameter is the Gleason score, and it is nothing but how the disease actually appears under the microscope. The second parameter is a PSA, which is simple a blood test. That PSA is a protein released by the prostatic cells, prostatic epithelial cells, and that can be measured by simple blood test. And the third is the extent of the disease. And that is assessed clinically by the digital rectal examination, or more recently, we can utilize the information gained by the imaging like an MRI. And fourth important parameter is the percentage of core biopsies positives. So based on these 4 parameters, we divide all the prostatic cancer patients into 5 major risk groups, as you can see on the screen. In a very low risk group, a low risk group, intermediate risk group, high risk group, and very high risk group. And when the disease metastasizes to the lymph nodes or a bone or any other metastatic site, then we divide that patient into the metastatic group. As far as the management is concerned of a prostatic cancer patient based on the risk groups, A very low risk group, probably they don't require any kind of a treatment. You can just observe this patient under the active surveillance. And very high risk group and the high risk group, probably those with a lymph node and locally advanced, that is loco-regionally advanced disease, probably they will go with the radiation and the hormonal therapy. Today's my topic of discussion is a low risk group and the intermediate risk group, which we call as the early prostatic cancer. And to manage the early prostatic cancer, we have several options available. The first and most important is a radical prostatectomy. During the radical prostatectomy, it can be the basic principle is surgeon goes inside, is take out the prostate and joins the urethra with the urinary bladder. Even the principle is say it can be done with an open, that is age-old technique, or a newer technique like a robotic or a laparoscopy. The second option available for early prostatic cancer is again a radiation. And the way we deliver the radiation, based on the delivery type, we divide into two kinds of a radiation. When we deliver the radiation by putting the radiation sources in and around the tumor, then the procedure is called as a brachytherapy. And based on at what dose rate is delivered per second, millisecond, or per hour, if radiation dose is delivered at a very low dose rate, then we call the brachytherapy is a low dose rate brachytherapy. And if the radiation is delivered at very high radiation dose, then we call it the high radiation dose HDR brachytherapy. Usually HDR brachytherapy is done with the temporary seeds, and low dose brachytherapy is done with the permanent seeds. The second way of delivery of a radiation is EBRT, that is called external beam radiotherapy. And the word itself indicates external means when we deliver the radiation by putting the radiation source outside the patient's body, then the terminology is used as external beam radiotherapy. And the majority of the external beam radiotherapy are delivered with now modern techniques like a linear accelerator. And modern technology, what we use in a radiation oncology is either intensity modulated radiotherapy or volumetric arc radiotherapy. And that is a conventional form of a radiotherapy, usually lasts for around 35 to 40 days. And if we deliver the radiation in a short course duration, like 5 fractions only, then the technology we use is SBRT. So based on the various treatment modalities, we have for early prostatic cancer, we have the option of a surgery, we have the option of a radiation, and again in the radiation, you can go for a brachytherapy, or you can go for a conventional radiotherapy, or you can go ahead with a short course radiotherapy, that is a radiosurgery, SBRT. So based on these options available, because the patients are having a luxury of options available. So the question comes in how we will decide which management patient should look for. And based on that, the number one criteria we apply as an oncologist or as a clinician is the first criteria we use is effectiveness, whether given treatment is effective or not. And in prostatic cancer, the effectiveness we measure in terms of whether that given treatment is able to control the PSA or not, whether that treatment is preventing the metastasis or not, or whether that treatment is adding some years to the patient's life, or whether we are able to prevent the death. When you compare all the modalities like a radiosurgery or a prostatectomy or a surgery, all these treatment modalities which I have mentioned are, in terms of effectivity, they are more or less similar only. Some minor differences are there definitely, but overall the effectiveness is similar. So if all the modalities are effective in then management, then how to go ahead with the choice of a treatment? There are certain subsets of patients which actually that decision depends on the patient's psychology. Some patient, the moment you tell them you are suffering from cancer, the moment they want it out from the body, and that subset of patients will definitely go for a surgery. There are other subset of patients who do not want to go and undergo or any kind of a surgery, and that kind of subset of patients will definitely go for a radiation. But majority of the patients will be confused because they are having so many varieties of treatment modalities available which are equivalent in the effectiveness. Then which one to choose. And that third criteria, and which is confused by the majority of the patients, will totally depend on the side effects, because we are getting the control, but we have to see that at what price we are getting the effectiveness. To see the side effect, okay, if the patient goes to the radiation oncologist will tell the patient, yes, radiation is the best treatment modality available, and there are a lot of side effects regarding the surgery. If the same patient goes to the surgeon, he will say that no, surgery is the best treatment options, and probably you will have a more side effects with the radiation. So there is a need to generate a evidence that is a scientifically correct evidence. And how to generate a scientifically current evidence in today's era, it is very difficult, because you type something in a Google and you will get at least few papers, at least few supporting data which will support to whatever you believe in. So the correct scientific data generation is very important, and that can be only achieved by conducting a well-designed randomized clinical trials. To sort this issue, there is a very good paper came from the Canadian Urological Association. What they did was an enormous work. They spent around 2 years. They formed a committee of 32 urologists and 8 radiation oncologists. So for every radiation oncologist, there were 4 urologists, and all these 40 doctors or experts form a committee. They met several times. They conducted almost 3 secret bailouts, and they came up with guidelines regarding all the treatment modalities and their associated side effects. We'll just quickly go through these papers, which I think it's very important to explain to all your patients what are the treatment modalities and what are the acceptable common side effects regarding that particular modality. So here we will go by question. The first modality is the surgery. Second modality is the LDR brachytherapy. These are nothing but the permanent brachytherapy seeds. Third modality is HDR brachytherapy. Usually we give after the external beam radiotherapy. And the fourth modality, conventional radiotherapy or a radiosurgery. So we'll go one by one with the questions. The first question comes to the patient mind is, how long will it take for a treatment? For the surgery, it will take around 3 hours for actual surgery to conduct, and patient may need 2 to 3 days prior admission to the hospital. If the same is done with a robotic or a laparoscopic advanced technique, probably the patient is going ahead with a lymph node dissection. Probably it will take little more longer durations, roughly around 3 to 5 years. For LDR brachytherapy, it's just a 2-step procedure. For first 30 minutes, we just do the prosthetic mapping, and after planning, we implant the seeds, and that procedure will long last for 1 year. 1 hour, and then after 1 hour, patient can safely go home. For SDR brachytherapy, again, it is a 2-step procedure. First day, we call the patient, we do the mapping, and after 1 hour, we treat the patient and we send the patient. For external beam radiotherapy, the actual treatment is of 5 to 10 minutes only, and depending on which technique you are going ahead. For a conventional radiotherapy, the patient has to come daily for a treatment on an OPD basis for up to 35 to 45 days. If we are treating the patient with a modern technique like a radiosurgery, then patient has to come for 5 fractions only. The second question, how long will it take for a recovery? The post-surgery, probably patient takes 2 weeks with the catheterization and another 4 weeks with the minimal strenuous activity. And for robotic surgery, it's usually a lesser duration of a catheter placements, and it's around 10 to 14 days with the catheter and additional 2 weeks of the minimal strenuous activity. For a brachytherapy or a total radiation therapy, usually there is no period required for the recovery. A patient can straight away go home. The third one is whether how much longer duration the patient needs to be catheterized. Again, as I mentioned, for the surgery, it usually takes around 2 weeks. And for LDR brachytherapy, sometimes what happens, we implant the seeds permanently into the prostate, and that leads to the prostatic edema, and probably it causes the urethral narrowing. And sometimes in LDR brachytherapy, that is permanent seed brachytherapy, usually less than 10% patients require catheterization, and that can be removed after 2 to 4 weeks. For external beam radiotherapy, no such catheterization is required. Very rarely it requires less than 1% or 5%. The most common side effects associated with the prostatic treatment is a stricture formation of urethra. So for the surgery, the chances are around 5% with open surgery, and only 1% with the robotic surgery. For external beam radiotherapy or a brachytherapy, the chances will be less than 5%. But if the strictures again develop, then probably patient do requires a dilatation, or rarely patient again requires the resurgery. The next common side effects associated with treatment is incontinence, urinary bladder incontinence. And if the patient goes for a surgery, probably it's around 20% patients require, 20% patients do have that urinary incontinence at the month of 6 months, and that person drops down to 10% at the end of the 1 year. For radiotherapy, for brachytherapy, it is less than 5%. And for external beam radiotherapy, just less than 1%. Then the urinary bladder bleeding. So for a surgery, no chances for a urinary bladder bleeding, but for radiation, definitely less than 2% for brachytherapy, less than 3% for external beam radiotherapy. And if you're combining both the treatment, one is the external beam radiotherapy along with a brachytherapy, then the chances will be roughly around 5%. The next common side effect associated is a rectal bleeding. If patient is choosing for or going for ahead with the surgery, probably there is no chance for a rectal bleeding. The rectal bleeding is minimal with the brachytherapy, roughly around 5%. But those patients who undergoes conventional radiotherapy or a radiosurgery, the probability of rectal bleeding will be very high, roughly around comes 10%. The next important side effects associated with the treatment is the sexual functions. And it again depends on the patient is going ahead with the surgery and with the bilateral nerve sparing, then probability is around 50% of a recovery of a sexual function at the end of 1 year. And if patient is going with the radiation, probably with the radiation, the sexual function will be maintained better as compared to the surgery. And again, it totally depends on the patient age, whether any comorbid conditions are there with like a diabetes mellitus or not. That all contribute to the sexual function disease. And the last question, which usually probably comes to my patient's mind, if patients are going ahead with the radiation, probably whether I will be suffering from the second malignancy or not. For surgery, no question about that, but for definitely for external radiotherapy, there are reported incidents of less than 1 or 2% of secondary malignancy, but the latent period usually it takes around 10 years to 15 years, and probably with the prostate cancer, they already are the disease of older patients, and life expectancy, if they are living more than 10 years, 15 years, and then definitely the chances of second malignancy will be definitely there. And regarding the effectiveness, because in the prostatic cancer management, treatment is effective or not, we measure that by the PSA level only. The moment patient undergoes the surgery, the PSA will be dropped down to the undetectable level, and it will remain the same as long as a recurrence is not there. When the patient goes for a radiation, the probability, the level of dropping of a PSA is not like goes to the undetectable, but probably it is coming down to the less than 0.2 nanogram with a brachytherapy, and it is little bit on a higher side in external radiotherapy, but still it should be in less than 1 nanogram per ml. There is a very wonderful a paper published by the NEGM, which is related to the patient-related reported outcome and not the doctor-related outcome. So, in that report, more than around 2,200 patients they have assessed with for the three modalities. One, those who underwent the radical prostatectomy. The second group is a radical radiotherapy, and third group is just an active monitoring. No treatment was offered to the patient group, and they saw that the side effects in terms of urinary incontinence, sexual quality of life, and the bowel functions. And then here you can see the red line in this. It's a radical prostatectomy. So probably through this paper you can see that the urinary incontinence and the sexual quality of life are little bit poor with the radical, those who undergo the radical prostatectomy, and the bowel functions like a radiation induced proctitis is more with a radiation group. But overall, if you see the same group, for a physical health score or a mental health score or anxiety index or a depression index, for all the modalities like a radical prostatectomy, radical radiotherapy, or active monitoring, all these indices are similar only. So at the end of the day, to just summarize the various treatment options and treatment modalities in the main, okay, the men with the early prostatic cancer who requires a treatment, they have a choice, and those all the treatment modalities have their own set of risk and benefits. Probably I would say those patients who worry more about the urinary incontinence and sexual dysfunction, probably radiation is the better way to treat with them. And those who are more worried about the radiation induced proctitis, then probably patient for them, that kind of a patient, surgery is where to go ahead. And since it is involving the multimodality approach, every patient should go with a multidisciplinary approach. That is, we call the tumor board meeting, and then the only treatment decision should be taken. And the one very important aspect is if I'm talking about the radiation, then radiation side related side effects, pros and cons should be discussed with a radiation oncologist rather than with a urologist, or surgical related issues should be discussed with the surgeons rather than the radiation oncologist. Sometimes we feel that we know everything, but in reality we know very little about the other faculties. Welcome, Dr. Rohit. Since I am a radiation oncologist, I will be the next segment of my talk is again the radiation therapy. See, basically, delivery of a radiation itself in an art, and why I call this in an art is, if I want to achieve a good control of a tumor, then probably I will increase the radiation dose. If the moment I will increase the radiation dose, the probability of a normal tissue toxicity will be very high. If I'm more worried about the normal tissue toxicity, then what I will do, I will just reduce the radiation dose, and probably I will be losing out on a tumor control. So there is a very narrow period or a narrow window where, as a radiation oncologist, we get where my aim is to give maximum dose to the target so that I will be in a position to extract the maximum tumor control at this same time with the minimum side effects. And that's the reason we call it is giving delivery is a art, and that requires a very advanced technology, and at the same time it requires a man behind the technology also, a man behind the machine also. So conventionally, we used to treat the prostatic cancer patient with very small doses delivered on a daily basis, and every 5 days a week, to total duration of around 39 to 45 days. So we used to call the patient for around 2 months for a radiation treatment. Okay. But over the period, with the evolution in the radiobiology of a prostate, we realized that the prostate is a very slow growing tumor. Okay. And those with a very slow growing tissue, they are very sensitive to if I increase the dose per fraction. Okay. With this understanding, increase in the understanding of a radiobiology for prostate, number one, and the number two is with the evolution of a modern radiation delivery machineries. Okay, we are in a position to deliver a high dose per fraction in today's era. So here you just for a comparison say, earlier we used to treat the prostate cancer for around, let's say, around 45 days, and the total dose we used to give around 80 gray. Then we realized with the evolution of a radiobiological, our understanding and the evolution of the machineries, we brought down that 45 days treatment to around roughly around 20 to 28 days, and that we call them the moderate or moderate hyperfractionation. And then we realized that if I'm giving a higher dose per fraction, then I need not to give 80 gray for every patient. If I can achieve the same radiobiological effect, let's say about if I'm delivering the 7 gray per fraction, then I can finish entire my treatment in 5 fractions only. And I don't need to give the higher 80 gray dose only. I can finish that around 36 to 40 gray. And that is where it is called as the radio surgery. Now the third portion you can see is a SBRT, is nothing but a stereotactic body radiotherapy. It is a very precise technique. It requires a very modern machineries, and it is a very precise technique, and it delivers the very high dose per fraction with a sub-millimeter precision. And then you can finish entire treatment in 5 fractions. So if I'm delivering the entire treatment in a 5 fraction, then probably that technique is called as SBRT. Some people call that as a SABR, that is a stereotactic ablative radiotherapy, or some people just refer it as a cyber knife. But cyber knife is nothing but it is not a technique. It is a machine which delivers the SBRT technique. But all said and done that, previously, see the radiotherapy we used to give for 45 days, and now we are coming down with a moderate hyperfractionation to 20 fractions and then to the 5 fractions only. But is it really effective? Whether the first question comes to our mind is whether it is safe to deliver such a high radiation doses, number one. And if we can deliver them safely, whether it is that effective or not. And to know these questions, we need to conduct the random, as I mentioned, to get the good evidence. We need a good randomized clinical trials. And here I am summarizing the very high level of evidence which support the SBRT as of now. So only last year only there are 3 beautiful papers presented in a very renowned journals. And I will be discussing only 3 trials here. The first trial came from the Sweden, that is hypo-RTPC. The second trial came from the United Kingdom with a PACE-B trial. And third one is a retrospective analysis. It is not a prospective randomized trial, but it is a trial. Yes. In the first trial, which came from the Sweden, what they did, they randomized more than 1,200 patients from 2005 to 2012. Among them, there were around 90% patients with the intermediate risk group and around 10% patient with a high risk. So none of the patients received a hormonal treatment. And you can see they were randomized with the conventional radiotherapy. That's 2 gray every day they deliver for 39 days, and total they deliver around 78 grays over a period of 8 to 9 weeks. And that arm was compared with a 6 gray, very high dose delivered in a single fraction. That 6 gray in a 7 fractions, total dose delivered was a 42 gray, and that treatment course duration was brought down from 8 to 9 weeks to the 2.5 weeks. And remember, in this trial, since this was conducted in 2005 to 2015, that most of the patients were treated with the old-fashioned radiation techniques, not with the modern techniques. And still you can see the failure-free survival. That means whether this conventional, whether this radiosurgery is as effective as conventional. You can see the graph, both the graphs for a conventional as well as the radiosurgery, they are exactly matching. The only difference was the acute toxicity. You can see here, red is a hypofractionation line, and the blue is a conventional radiotherapy. in terms of urinary incontinence, in terms of bowel symptoms, in terms of sexual functions. The acute toxicity was little bit higher in a radiosurgery or SBRT arm, but you can see that it is increased up to only initial 3 months only. After the 3 months, again you can see the both the lines are exactly matching. So in conclusion, that with the SBRT, probably there are more acute side effects. Effective wise, they are as good as the conventional radiotherapy, but with a little bit increase in the acute toxicity, and the lead toxicity is a similar only. And here I'm giving some absolute numbers which are published in this trial. You can see the grade 3 reactions for a urinary bladder at 5 years was comparable with a 4.2 to 4 versus 4.7%. And for bowel, for grade 3 reaction is around 1.5 to 1.9. And remember, these are the absolute numbers which are coming from a remote technology, not with a modern technology. And the next trial we will see where the techniques were used with a modern technology. The next trial is a phase B trial which came from the United Kingdom. And this trial is a recent trial which is conducted started in 2012 and concluded in 2018. More than 800 patients were enrolled in this trial. And this trial, you can see there are in conventional arm, there are two arms. One is with a 2 gray delivered into 39 fraction, that is a standard arm. But when this trial was started, the practice in the United Kingdom came down from 39 fractions to 20 fractions. So again, the modern SBRT arm was compared with a moderate hyperfractionation also. And in this trial, none of the patients were received the hormonal therapy. It is a purely again a radiation therapy trial. But the most of the patients were treated with the modern IMRT technique. Only limitation of this trial is it has a very short follow-up because it concluded in 2018 only and published in 2019. But in this trial, you can see the acute toxicity, not the lead toxicity, because it doesn't have that longer duration. So with a modern technology, you can see in the blue is the conventional, blue is the SBRT arm, and the red one is the conventional radiotherapy. And again, the lines, both the lines are matching with each other in terms of urinary continence or urinary obstruction or urinary bother or sexual function or a bowel functions. And you can clearly see that in terms of acute toxicity also, patients do definitely have a more acute side effects with the conventional radiotherapy as well as with the radiosurgery also. But you can see all at the end of the 12 week, they are again coming to the normal. So all these acute side effects usually get settled at the end of the 12 week or 3 months. The third trial is a retrospective analysis involved more than 2100 patients. Those who patients received SBRT, purely SBRT from the 2000 to 2012. And this trial has longer data, long-term data. It's a median follow-up data is 7 years. That means around more than 50% patients beyond 7 years, they are living. So here you can get the acute toxicity as well as the lead toxicity and the effectiveness also. And look at the numbers. Grade 3 in first trial, the urinary side effects were around 4.2 to 4.0%. But with the use of a modern technology, that acute side effects brought down to the 2.4, around 2.4%. And bowel toxicity from 1.9% to straight away 0.4%. So in conclusion, with all these three trials, first trial gives us the evidence that with a remote technology or older technology, it is more safer. SBRT radiosurgery is more safer. With the modern technology, second trial gives us the evidence of modern technology. It is a safer and effective. And the third trial gives us the effectiveness, the acute toxicity, as well as the lead toxicity. So this is considered as level 1A evidence for the radiosurgery, and you can say that safely that using the SBRT is a safer way, and you can get the equivalent result as a conventional radiation therapy. I'll just quickly run through 4-5 slices how actually we deliver this SBRT process in our radiation oncology department. There are 3 phases involved. First is a actual planning of a treatment. Second phase is actual delivery of a treatment, and then third is a follow-up and the PSA monitoring. So you look at the anatomy of a prostate. Here is a very enlarged prostate. Okay, prostate basically is a very notorious organ to treat because it is surrounded by a notorious organs like a rectum and the bladder, because it has a certain internal motions because of a urinary feeling or a rectal feeling. So if you are delivering very high precision, high radiation dose per fraction, then precision among highest precision is required. But since that prostate is surrounded by 2 such organs which daily moves during the treatments, and that's why we have to be very careful. We have to monitor the movement of a prostate daily, otherwise it will be very disastrous to treat the patient with a very high dose. Then how to tackle these treatment motions? So what we do is we place the fiducial markers. These are nothing but gold sheets. We ask the patient to come to put these markers through local anesthesia. We give the antibiotic covers. It's just a simple USG guided procedure. Takes around 30 to 40 minutes. Okay, and we once the fiducials are placed, then we give time for at least two days to settle these seeds, and then we can track these seeds after the placement. And with this tracking, we can easily look at the prostate and you can deliver the radiation. The second worry about the radiation oncologist is again the very high dose to the rectum, because rectum is a very sensitive organ. We don't want to deliver a high dose to the rectum. So sometimes what you not all the patients do require this, but if the prostate is very enlarged or very large and very close to the rectum, then probably you can just separate these prostate, or you can push away the rectum from the prostate by placing the hydrogel in the fascia between the prostate and the rectum, and that is called as a rectal spacer. So when you are pushing away the rectum more away from the prostate, the probability of radiation delivered to the rectum will be very low, and you can reduce the radiation related toxicity to the rectum. So once the patient comes to our clinic, we explain all the radiation pros and cons to the patient, and with well informed consent, we prepare the patient for a simulation, actual simulation. Before taking patient to the actual simulation, we ask the patient for a bowel preparation, and then we give the patient for a urinary bladder protocol. That is, once the patient comes to the department, we ask them to evacuate the urine, and then we give them the half liter of water, and we ask them to wait for 30 to 40 minutes. And this is called as a bladder protocol, so that every day we will get the same bladder feeling, and that will be easier to reduce the dose to the bladder. Then we prepare the mold, that we call them the immobilization preparations, and then we take the CT scan with a 1 millimeter thickness. But CT is not a great imaging modality to mark the prostate cancer or a seminal vesicles. Probably MRI is much better imaging modality for a soft tissue resolution, and for urethra also. Sometimes when we deliver the stereotactic radiosurgery, so the urinary stricture will be more with the patient, those who underwent usually TURB. Post surgery, if you are doing the radiosurgery, then the chances of urinary structure will be little higher on a higher side. So we take the CT scan, we take the MRI images, we fuse both the images, and this is nothing but our treatment planning system. Here you can see very nicely prostate is marked anteriorly, the urinary bladder is marked, posteriorly the rectum is marked. We tell our system, that is treatment planning system, this is my target, these are my organ at risk, and we want to deliver maximum dose to the target only. At the same time, we want to save the prostate and the save the rectum and the bladder. Once the plan is generated, we do the analysis, how much dose the organ at risk are receiving. Once we are satisfied with the planning, then actually we take the patients and we deliver the radiation treatment under the image guidance. We take the patient for actual treatment. Our machine is having the inbuilt CT scan in the machine. Before delivering the treatment, we take a imaging, we match the image, and we track the prostate with the help of fiducial markers, and then we are happy with the exact matching, then only we deliver the treatment. And the actual treatment will be only for 10 to 15 minutes only. So once we are done with the radio surgery process, we ask the patient for a follow-up with the clinical examination and the PSA monitoring. We do PSA monitoring every 3 monthly for first year, then 6 monthly for 2 to 5 years, and then yearly afterwards. Post radiation therapy, the PSA, how the PSA will fall. Here you can see the in the cartoon. First 3 months, the PSA will fall very rapidly, and then after the 3 months, it will reduce at a very gradual pace, and it will achieve the nadir level around 40 months. Some with surgery, it will go to the undetectable level at very rapid space. But with the radiation, as I mentioned, it will go only below the 0.05 nanogram per ml only. Okay. One must aware about the, it's a very funny parameter, that is PSA. We call it as a PSA bounce. This appears with basically with a radio surgery, and this is nothing but around 25% of patients will experience a benign rise in a PSA, and that PSA usually it happens around the 18 months, and we call them a PSA bounce. The actual reason we do not know, but sometimes in around 25% it happens. Then how to differentiate whether it is a true recurrence or just an PSA bounce? You can look at the level. If it is increasing less than 0.5 nanogram per ml, then probably it is a PSA bounce only. If it is increased more than that, then you can consider that for a biochemical failure. You can consider that. But this benign phenomena, again, usually it happens around 18 months only, and it's after another 18 months it will get settled. So no need to panic PSA bounce. There is enough high-level evidence which support the SBRT. There are several ongoing trials which are actually designed to whether it is not just equivalent, but whether it is SBRT is giving us a superior result or not. And it's very convenient for the patient. It is just a 6-day treatment. For 1 day is for a planning, and 5 days treatment delivered on an alternate day. So in totality, we came from around 2 months treatment to just a 6 treatments, just a 6 hospital visits only. And it has effectively, it is controlling the PSA level. Okay. And still this role of radiosurgery is still limited to the early prostatic cancer with the intermediate risk group only. So now there are ongoing trials are going on whether we can utilize the same techniques for a high risk patient or those patients with a recurrent after a surgery after prostate cancer. Thank you very much. And once again, I thank IMA Haji Ali and the INTAS for giving me the opportunity. If any question, please feel free to ask.
Yeah, thank you, Dr. Dilip Nikam, sir. We have few questions.
Yes, sir. Yes.
In the question answer box. Yeah. One is from Dr. A. Jain. After radical prostatectomy, yes, patient get incontinence, yes, and impotency. How to treat it?
Okay, that's the reason. So it's a better way to send this patient to me, sir. Radiation will have little bit lower urinary incontinence and the sexual function. So that's the reason today's my topic was to, if the patients are more worried about the urinary incontinence and the sexual function, probably radiation is the treatment of choice for them.
Yeah. One more question is there. Yes. In radiotherapy, are rays given from outside or probe is kept in the rectum side effects of radiotherapy in SRBT. So there are two questions in the same. Is the rays given from outside or probe is kept
Yes, sir.
into
Yes, sir.
rectum?
See,
And another is
again, the way we deliver the radiation, that they are called as a brachytherapy technology and the external beam radiotherapy. In a brachytherapy, we place the permanent radiation sources inside the prostate only. That's called the brachytherapy. Today, I have discussed about the external beam radiotherapy, that is a radiosurgery. It is given through the machine only. The source is in the machine. Patient will lie down on a couch, okay, and the radiation will be delivered from the outside the body.
Yeah, thank you very much, sir. We had a very great informative talk from you. Now I would like to invite Mr. Deepen Mehta, who is the COO DigiShield. He will brief us on digitalizing medical records and its importance. So Deepen Mehta, sir, please.
Thank you, Doctor. Thank you, Dr. Sachin. Thank you, IMA, for having DigiShield as your technical partner in managing the webinars. Siddharth, just can you stop the screen sharing? As you can see, in current situation, how India and other countries are moving towards the digitalization, towards adopting the new technologies. But in India, we are far away behind as compared to the foreign countries. As we see in foreign countries, more than 95% of countries are adopting some of the EHR applications and adopting the technologies. But in India, still around 30% only major big hospitals and doctors are using some of the softwares to maintain their medical records. So in India, around 70% are yet to adopt the technologies. So there are various other regions which doctors are facing and challenges in adopting the technologies. The one of the major reason is cost. So it requires initial investment into computers, laptops, or servers to adopt technology. So that's the reason for a high cost of implementation. Doctors are facing it difficult to adopt the technology. Second is a language barrier. So in tier 3, tier 4 in villages area, there are many of the doctors or patients who are not well versed with the English. So software available in the market are of languages in English. So this is also one of the major challenge in adopting the software in village areas as well. Another challenge which doctors are facing is techno savvy. So doctors are not used to in the adopting the new technology. They are not aware of benefit of EHR. They are far way behind into adopting their traditional way. They are just used to write, take the paper prescription, write on the paper and hand over the hard copy to the patient. So which is also find difficult for the doctor to change their habit or change the mode of prescribing the medication. Even they are not aware of what are the benefits for the doctors to have or adopt the new technology or adopt EHR. So one of the main another challenge is computer literacy. So it requires huge implementation costs, training knowledge, which disturb their ongoing process and workflow. So what are the benefits if doctor adopt the EHR? What doctor will be benefited is they can maintain their patient's medical record, which helps them to build the relation with their patient. Even the doctor can view the patient's previous medical record. Entire patient history can be viewed by the doctors. There are even various patients of doctor's family patient. Suppose there is a patient of a diabetic, in which doctor have them to do HbA1c test for every 3 months. And suppose if a patient has done a HbA1c on 1st January, after 3 months, on 1st April or first week of April, it's due to have one HbA1c. But doctor or patient, if forgot, they have done the HbA1c on the 1st of January. So it faces difficult to find the data there or list in what was the previous day patient has done the HbA1c. So if doctor adopt EHR, they can view all the previous medical records, all the previous medication, and what is the previous day the patient has done their test. So accordingly, they can recommend the patient that so and so date is due for your HbA1c test or blood test. So which helps the doctor and patient to increase their relationship as well. In currently, what doctors are doing, they are doing video consultation or teleconsultation through WhatsApp or other medium. But in such cases, what happens that if doctor sends the prescription through the WhatsApp, and doctor has done the video consultation, and patient has not paid the consulting fees or forgot to pay the consulting fees. So it's even risk for the doctor as well in collecting and receiving their consulting fees. So DigiShield will help doctors even to avoid this risk as well. So we have on health pay feature, which is online payment mode, in which even if doctor has done a teleconsultation or video consultation, and doctor send the prescription to the patient, but prescription will not be viewed by the patient unless and until patient has made the consulting fees. So if even doctor has done a video consultation and patient clicks on the prescription link, it will show message to the patient that please pay or so and so consulting fees to view your prescription. So once the patient will make the payment, then only patient will able to view the prescription. So it's risk free for doctor as well. And it is also benefit for the patient and the doctor to have that all the pending reports or all the pending fees, all the pending expenses, everything can be tracked by the doctor as well. So even DigiShield can help doctor in maintaining their day-to-day number of patient visited, the number of patient visited per day, monthly, quarterly, analytical reports, all research and analysis reports, everything can be viewed by the doctor itself. And it's very simple and easy to use. There is no need to have techno-savvy for the doctor as well. They have to just follow the traditional method which they are used to prescribe the medication. Write on the prescription, click the photo, patient will receive the SMS of the prescription. Even patient doesn't need to download any software or application. Even just the web browser is needed for the patient. Even the patient doesn't have the smartphone as well. Then also with the web browser, patient can view the prescription through just a short SMS link. Patient just need to click on the link which they have received in the SMS. So even various other features are available in the DigiShield. The one even online appointment booking, appointment scheduling, teleconsultation, telemedicine, online payment. So even for online appointment booking also, or even on the spot booking also, it helps the doctors to maintain the queue of the patient. So many times it happens that there are 20 or 30 patients waiting outside the clinic. So in their DGC lab, doctor can view the number of patient waiting outside. So the patient appointment queue management can also be help doctors in maintaining their clinic and maintaining the patient's appointment. Even patient will receive the follow-up SMS as well for as a follow-up reminder. Suppose doctor has done a consultation on say 20th of December, and doctor says the patient that you have to visit on for the follow-up visit on 25th of December. So in such cases, what happens that doctor hand over the hard copy to the patient, and on the 25th of December, when patient visit for the follow-up, patient forgets their hard copy or their previous prescription. So if doctor are using the DigiShield, even that will help the doctors to view their previous medication. If patient forgets their hard copy, no need to worry for the doctor and patient as well. Doctor can view the entire previous prescription or previous medication on the one go. So it's very easy and very handy to use digital software. Would recommend doctor to adapt this and start using if they are not downloaded. And it's available free for the lifetime for the doctors, and it's available from both iOS as well as Android iPhone. Even we have now updated the event tab in which doctors can view the upcoming webinars, and doctor can view their previous webinars. Doctor can even register for the webinar through the app, and they can view their webinars they have attended. They can even view their digital certificates generated for the webinars as well. So would recommend doctor to start downloading Digital and start adopting the technology, which will benefit for both and which will help doctors to maintain their complete entire medical records. You have any questions or any query, you can always reach us. You can even contact us on www.digishield.me.
Yeah, thank you, Mr. Dipen. There is one question in your chat box. You can answer them separately. Now, I would like to introduce Dr. Rohit Pai. He's our next speaker. Dr. Rohit Pai is an associate consultant, medical oncology, Bombay, visiting medical oncology, BYL Nair Charitable Hospital, Mumbai. After Medical College and Sion Hospital, he did MD Internal Medicine and DM Medical Oncology from AIMS New Delhi. He then completed DNB Medical Oncology and MRCP and also received European certificate in medical oncology. He holds a academic career, securing distinctions and gold medals at all levels. He has been the recipient of the numerous awards at city, state, and national level. His field of interest are GI oncology, head and neck cancers, breast cancers, and immuno-oncology, as well as hematological cancers. So I request Dr. Rohit Pai to deliver his talk.
Thank you so much for the kind introduction. I would like to speak about update in systemic therapy in cancer prostate. And just as a reminder, Dr. Dilip Nikam took the radiotherapy part, and I'll be talking about the systemic therapy, the hormonal therapy, chemotherapy, the newer hormonal agents in cancer prostate. We at Bombay Hospital now have a multidisciplinary team, including surgeons, the new department of radiotherapy, and I take care of chemotherapy along with my other colleagues. Next slide, please. So, as a brief introduction, prostate cancer in India, it is a significant problem. This is the Global Cancer 2008 data. So, as you can see, the incidence, the new cases are approximately 19,000, and the prevalence, the 5-year prevalence, is around 60,000. And prostate cancer is responsible for approximately 12,000 deaths due to cancer in India. Next slide, please. So just a brief case to start. 72-year-old shopkeeper having uncontrolled diabetes presents with backache and urinary difficulties in 6 months. PR examination reveals a hard prostate. So how would you evaluate him? Next slide, please. So workup for a suspected case of cancer prostate, the most important physical examination is a PR examination, which we have already done. We have to do the routine parameters, the complete blood count, RFT, LFT, electrolytes, including calcium, because sometimes multiple bone mets are associated with hypercalcemia. Serum PSA level is the next step. And how to confirm the biopsy is by a TRUS-guided, transrectal ultrasound-guided biopsy, which you can see at the lower left corner of your screen. So there is an ultrasound probe inserted in the rectum. Then under the guidance of that probe, you insert the biopsy gun and you take multiple cores of the prostate gland and you send it for histopath. In histopath, one of the more important thing is something called as Gleason scoring. So that is towards the right hand side, lower corner of the slide. So Gleason scoring is the glandular appearance, how differentiated it is, how close to the normal prostate it is, or it is very bizarre, abnormal. So there is a Gleason score, which determines the aggressiveness of the tumor, and this is a very important thing which should be noted in the histopath. Then the next logical step is how to stage the tumor. So how far it has spread. So previously a CT scan, abdomen plus pelvis, as well as a bone scan were used to be done. But for this patient, let's see what was done. Next slide, please. So the gentleman underwent evaluation. PSA was very high, 109 per nanogram per ml. CBC, RFT, LFT normal except raised alkaline phosphatase. Raised alkaline phosphatase is an indicator that there might be bone metastasis. And in prostate, the bone metastases are considered classically as osteoblastic metastasis. So they are associated with new bone formation rather than destruction. He underwent a trust-guided biopsy, which revealed prostatic adenocarcinoma in all pores, lesion 8, so which revealed that the tumor was aggressive. He underwent something called as a PSMA scan, prostate-specific membrane antigen scan, which showed metastasis in the lungs, retroperitoneal nodes, ribs, D5, D7 vertebrae. Because of that, he was having backache, also L5, and also the pelvic bone. And now we come to the treatment. So next slide, please. So what are the upcoming tests in prostate cancer? So for local prostate cancer staging, so suppose you are having a localized prostate cancer, especially multi-parametric MRI, which is there to the left of the screen, is the test of choice. There is something called as PIRADS, like you have PIRADS in mammogram when you are determining whether the cancer, whether the lesion is malignant or benign in the mammogram, which you do for breast cancer. So similarly, PIRADS, prostate imaging reporting and data system. So that is PIRADS, which is used in prostate cancer. And multiparametric MRI is the upcoming new modality for determining the local spread of the cancer. For the systemic spread, previously we used to do CT scan as well as a bone scan. Nowadays we do something called as a PSMA PET scan, prostate specific membrane antigen. Again, something which is available in all the leading hospitals. It is available in Bombay Hospital. It is available in PET centers also. So here you can see that you towards the right that there are some spots in the ribs, there are spots in the vertebra. So that reveals that there is cancer spread there. PSMA is physiologically up. There is a physiological uptake of PSMA in the salivary glands, the liver, the kidney. So the normal is also showing some uptake, but those additional things towards the right hand side are the abnormal foci of PSMA uptake, and this is something which is the next step in prostate cancer staging, especially the newest modality, PSMA PET scan. So next slide, please. So now we come to the main topic at hand. And now in systemic therapy, the talk will predominantly focus on androgen deprivation and something additional to androgen deprivation. So prostate cancer is an androgen dependent tumor. Even benign prostatic hyperplasia, which is the benign variant, depends on androgens. So suppose you curb the production of androgens or you curtail their action, the prostate cancer cells will die. So who discovered this? The gentleman's name was Charles Huggins. He got a Nobel Prize for the same in 1966. And any talk of systemic therapy is incomplete without his mention. He determined that the effects of castration on prostate cancer by serially monitoring the acid phosphatase levels. So in patients with prostate cancer, acid phosphatase increased, showed that the tumor was increasing. You castrate them, remove the testicles, the acid phosphatase levels fall, and this was the seminal discovery in the field of prostate cancer. Next slide, please. So this is a very complicated slide. I would not like you to get worried seeing this slide, but the important thing is remember that testosterone or the androgens are synthesized in the testicles. Obviously, the Leydig cells secrete it, but they are also synthesized in the extra testicular tissues. They are synthesized in the prostate gland itself. They are synthesized in other tissues like adrenals. And you can see towards the left-hand side of the screen, there is one enzyme called as 17-alpha hydroxylase, which catalyzes the conversion of progesterones to subsequent testosterone precursors. So this is another target for androgen deprivation, which I will be talking about later on. So androgen axis is a complicated axis, but this is one step which is important. Next slide, please. So who regulates the secretion of androgens? So you have the hypothalamic pituitary system. So you have GnRH, which is secreted by the hypothalamus, which goes to the pituitary, the anterior pituitary, and there is secretion of LH and FSH, luteinizing hormone, follicular stimulating hormone. This GnRH is secreted in a pulsatile manner. It is not secreted continuously. So to prevent the secretion of androgen, we can just inhibit the secretion of this GnRH. How do we do that? So coming to the third row and the fourth row, we can do it by GnRH agonists or GnRH analogs, which will continuously stimulate the pathway and cause down regulation of GnRH receptors, or we do it by antagonist, which will block the action of GnRH. So both agonists and antagonists essentially perform the same action, that is inhibition of GnRH and reduction of androgen. So you have testosterone synthesis in the previous slide, and you have GnRH pituitary axis in this slide. Next slide, please. So when a patient like our patient with a metastatic prostate cancer comes to us, the first step we do is ADT, androgen deprivation therapy. And what are the methods for it? First method is bilateral orchidectomy. So source ablation. You remove the source of testosterone secretion, which is the Leydig cells in the testes. And that is the simplest and the cheapest method, and it is permanent. So suppose you want to give ADT transiently. Suppose you have a localized cancer in which we do use it sometimes. I'll talk about it later on. You usually don't prefer this because once the testes are removed, it is a permanent androgen deprivation therapy. To the right, you can see the steps of orchidectomy. It is a basic, simple procedure. It can be done under nerve block or local anesthesia also. The second way to do ADT, androgen deprivation treatment, is, as I had mentioned, GnRH agonists. So continuous stimulation, continuous release of GnRH will actually cause reduction in androgens. So what are the drugs which we use? We use drugs like leuprolide, goserelin, palmoneril. Depot preparations are there. So usually we give it once in 3 months, can be given once in 6 months, it can be given monthly. There are various doses and formulations available. It may cause initial flare because what happens is in the end, we are giving GnRH agonists. So agonists will initially act as the normal GnRH and will initially increase the levels of androgen. After 3 to 4 weeks, after the continuous persistent stimulation and the down regulation of the receptors, the maximal testosterone levels are achieved. So this flare is very dangerous in patients like our patients. So sometimes if you have a spinal cord compression, that flare might actually lead to pressure on the spinal cord, neurological deficit, or it might actually cause urinary obstruction and renal failure in rare cases. So we should be very careful in using GnRH analogs, especially in patients with potential spinal cord compression or urinary obstruction. In them, we usually give testosterone blocking agents like bicalutamide. They are anti-androgens, oral, for at least 7 days, and then we give these GnRH analogs, because if the androgen is increased, if there is a flare, you have something blocking its action on the tissue. So these anti-androgens will work on the tissue and will block its action. So please remember, GnRH analogs, good drugs, but potentially have a flare reaction. So in critically ill, should be used with caution. The next is GnRH antagonists, so which block the receptors. Degarelix is the more commonly one available. One new agent has come called Relugolix, which is not currently available in India. And it is used especially in patients, which I had mentioned earlier, patients of impending spinal cord compression or urinary obstruction. Okay. How are these GnRH analogs given? So GnRH analogs are given either subcutaneously or intramuscularly, depending on what formulation you are using. And many a times, our colleagues, our physicians, general practitioners help us in managing those metastatic prostate cancer patients, because it's a simple enough injection, does not require hospitalization, can be given on an OPD basis. Next slide, please. When do we use ADT? So do we use ADT for all? Do we use ADT when you are undergoing a radical prostatectomy? No, not really. So high risk localized prostate cancer, like Dr. Dilip Nikam had mentioned, in which we are using the novel radiotherapy, in them, if there is a high risk localized prostate cancer, so the Gleason score is high, or you have a tumor extra prostatic spread, you may consider 2 to 3 years of adjuvant. So after the radiation, 2 to 3 years of androgen deprivation therapy. In them, obviously, orchidectomy is not preferred because it's permanent. You give either GnRH antagonists or agonists. all metastatic prostate cancer have to be given androgen deprivation therapy. Okay, all metastatic prostate cancer patients have to be given. So our patient, which we have discussed, will have to be given androgen deprivation therapy. It is also an option for biochemical relapse. So what is this biochemical relapse? Suppose you have a patient who has undergone radical prostatectomy, and as Dr. Dilip Nikam also mentioned, the PSA level will fall down to 0 if the patient has undergone radical prostatectomy. So suppose slowly after 2 years or 3 years, the PSA starts rising again, and you do a scan, the PSMA scan or something like that, and there is nothing there. So there is just PSA which is rising. In them, also we can just consider androgen deprivation, right? Goal is castrate level of testosterone. So testosterone level should be less than 50 nanogram per deciliter. So orchidectomy will obviously ensure that very quickly. GnRH agonist will take some time. Antagonists act much faster, but the goal, the castrate level of testosterone is considered to be less than 50 nanogram per deciliter. Next slide, please. So ADT in metastatic setting, how good it is? So it has very good response rates. Suppose you have a patient who is not affording, so I work in Nair Hospital also as well as Bombay Hospital. ADT is something which should be given to all metastatic prostate cancer patients, and orchidectomy is something which can be easily done. There is an objective tumor response, which is shrinkage of tumor in more than 80% of patients. It can normalize the PSA in more than 90% of patients. It improves the quality of life by reducing the bone pain and complications like spinal cord compression and urinary obstruction. And it is a palliative treatment in metastatic cancer setting. It's not a curative treatment. And eventually, the tumor cells become castrate resistant. So this hormonal effect will last for some time. It may be a couple of years to 3 years, but eventually the tumor will become castrate resistant. The PSA will start rising again. The tumor cells will start growing again. There will be new metastasis. But even a basic ADT will provide a good survival, good response, and a good quality of life to metastatic cancer patients. Next slide, please. ADT is associated with adverse effect, which no one talks about, especially in a metastatic setting. The benefit of ADT is much, much more than the potential adverse effects. But this is something which should be discussed when you are using it. Am I audible?
Yes, sir.
Am I audible?
Yes, sir.
Yeah. So ADT is used in, especially when you are using it in localized cancer, side effects need to be discussed. So what are the side effects of androgen deprivation? So fatigue, loss of libido, erectile dysfunction, hot flashes like something akin to menopause in females, osteoporosis, and cardiovascular side effects. So increased lipid profile, insulin resistance, cardiovascular toxicity, because what they say is those atheromatous plaques have FSH receptors. So if you are suppressing androgen, you can have rebound increase in FSH, and that can cause plaque instability. So especially important to discuss the side effects of ADT. Also, it is said that the antagonists, the agents like degarelix, are associated with slightly less cardiovascular toxicity than the agonists, because agonists will first increase and then decrease. Next slide, please. So what is the natural history of prostate cancer? So this is a graph. So initially you have local therapy and you may give androgen deprivation, and essentially the initial, it may be asymptomatic, non-metastatic, but subsequently you can have metastasis which are asymptomatic, so very low volume metastasis. And then once the metastasis start increasing, like involving the bones and the vital organs, then you have the symptomatic metastasis. Initial part, it is all castrate sensitive to, so ADT is a good enough treatment, but subsequently the tumor cells do develop resistance and do develop a phase called as castrate resistant prostate cancer, in which, please remember, whatever ADT was going on is continued, but we have to add something else. Next slide, please. So this is the androgen dependent versus androgen resistance difference. So testosterone is still uh, responsible for growth of tumor in androgen dependent, but in androgen resistance, there are other pathways like intratumoral or adrenal testosterone, which is responsible for growth. The androgen dependent can be just managed by whatever I have told you, orchidectomy or the injections, but the castrate resistance needs additional treatment like chemotherapy, newer anti-androgens, etc. Next slide, please. So what are the systemic therapies used in castrate-resistant prostate cancer stage? So the ones in bold are the ones we use commonly. So cytotoxic chemotherapy, 2 drugs. The most important drug is a drug called docetaxel. The second drug is a drug called cabazitaxel. The newer anti-androgens, abiraterone, enzalutamide. There are others which are used. Few of them are not available here, like radium 223, which is bone targeting agents for prostate cancer bone mets. Sipuleucel T, which is a sort of a vaccine against prostate cancer cells, and estrogens like progesterone. So please remember the top two. Next slide, please. As far as chemotherapy goes, the most important chemotherapy is docetaxel, which is a taxane which inhibits the microtubules in the cells, and it is an intravenous drug. Next slide, please. So what is the update? So this is update in systemic therapy. So this till now, whatever I was talking, I think probably is something which is basic. But the update is the therapies which were used in castrate-resistant prostate cancer have shown survival benefit if used in the early phase. So suppose you have a metastatic cancer patient. Previously, the treatment used to be just androgen deprivation therapy. It used to be just orchidectomy, or orchidectomy, or it used to be a basic GnRH agonist or antagonist injection. So now they say that you have to do more, and if you are doing more, you can have additional survival benefit. So these are two trials. One is a charted trial for docetaxel, and the other one is the latitude trial for abiraterone. I'm not going to go into details, obviously, but you can see that the two curves, the survival curves, are separating. So to the left, you are seeing that addition of chemotherapy to hormone sensitive metastatic cancer patients. So upfront, not later on when everything is becoming resistant, is showing survival benefit. And to the right, you can show you are seeing that additional of abiraterone, a novel anti-androgen, to the conventional ADT is also showing survival benefit. So whatever was used later on, many of them can be used earlier because there is a survival advantage in such patients. Next slide, please. So docetaxel, suppose we are using, it's very easy to say that chemotherapy lagao. I am a medical oncologist, obviously it's very easy to say, but no. So we have to talk about the toxicity also. So toxicity of docetaxel, suppose now I am saying that from that resistant phase, I have to use it earlier. So what is the toxicity? Toxicity is hepatic dysfunction, myelosuppression, infusion reactions, fluid retention. You do require steroids to prevent the fluid retention when you use docetaxel. You can use granulocyte colony stimulating factors, so GCSF in selected patients. Very important is need to counsel for strict fever charting. So our prostate cancer patients are elderly. Prostate cancer is a disease of the elderly, and you are giving chemotherapy in these patients. Important to prevent sepsis or febrile neutropenia, strict fever charting. So it should be a well-educated person who will listen to your instruction, and you will have someone around to administer antibiotics, etc., in case you have a fever. What are the other side effects of docetaxel? You have fatigue, neuropathy, rash, nail changes, and GI issues like diarrhea. Okay, so it is associated with toxicity. There are another logistical issues. So you require hospital administration, maybe a daycare admission for around say 4 hours, and you require it for a total period of 6 cycles. So 21 days, cycle is repeated every 21 days for 6 cycles. So that much period is spent in giving chemotherapy. And definitely it has a survival advantage, but it has its own toxicity. The advantage of docetaxel is it's a very cheap drug, especially in a government setting like Nair where I work. It is a IV drug which can be given in my daycare. So it's a very cheap drug. The second advantage is in patients who are having a lot of disease burden, high volume disease. So disease in the liver, multiple bones, etc., everything. But in them, docetaxel can act rapidly, and it does have certain benefits. Okay, so docetaxel is one option which can be used. It can be used earlier in hormone sensitive setting. It can be used later in castrate resistant setting also. Next slide, please. So what are the newer anti-androgens? So as I had mentioned, there are other pathways which become active in castrate resistant prostate cancer setting. So they are like adrenal dependent or tumor tissue dependent. And I had mentioned one hormone in the initial slide, 17 alpha hydroxylase. So abiraterone will inhibit, it's an oral medicine which will inhibit that hormone, and it will result in decreased synthesis of the androgens in the other areas like adrenals or the tumor tissue. It is given orally with steroid because inhibition of androgen can also sometimes lead to adrenal suppression. So you give steroid, and adverse effects of abiraterone are hypertension, hypokalemia, cardiovascular side effects, liver function test abnormalities. And there was a latitude trial, the curve which I had shown earlier, which showed that it is beneficial even in patients who are presenting to you with metastasis. You give them ADT and you give them oral abiraterone, it will have survival benefit. Next slide, please. Another drug is enzalutamide. Again, this is an androgen blockade. So the previous one was an enzyme inhibitor. This is an androgen blockade. And it is a newer anti-androgen. The older ones were drugs like bicalutamide, which you might have heard, its brand name is Tabi. The enzymic trial showed benefit like abiraterone. It can also have a benefit in the upfront hormone sensitive prostate cancer. Again, it's an oral drug. Side effects are falls or seizures in 1% of cases, but it does not require steroids. So that is the advantage. And again, so you have basically three options right now if a patient presents with metastatic breast cancer. Everything should not be given together. Please let me make it clear. So either you have IV chemotherapy docetaxel, you have oral abiraterone, or you have oral enzalutamide, and you have to choose which one to give. Next slide, please. So how to choose the therapy? So it depends on comorbidities. Like our patient had uncontrolled diabetes, the one I had mentioned. It depends on cost. So the cost of docetaxel is very cheap. So it can be covered in maybe 6,000 to 7,000 per cycle, not very high. And it is a limited therapy. So docetaxel, if you are giving IV, it is only for 6 cycles. It's not an ongoing therapy. But importantly, enzalutamide as well as abiraterone are ongoing. So you have to give them till they are beneficial. You cannot stop them in between. The cost of enzalutamide from 50,000, 45 to 50,000 has come down to 20,000 because of her generics. Abiraterone was also expensive, but the cost of abiraterone is now 8 to 10,000, and this I'm talking about is monthly therapy. So enzalutamide 20,000 per month, abiraterone 8 to 10,000 per month. Patient preference. Some patients say I do not want IV chemotherapy. In them you have to offer them oral treatment. There are other patients who say that मुझे chemotherapy दो क्योंकि मुझे बार-बार daily मैं भूल जाता हूँ. I forget to take a daily pill. So in them you have to consider chemotherapy. And very importantly, you have to sequence the therapies. So suppose you are giving docetaxel. If later on the disease increases, what is left with us? We can still give them the other one of the other two agents. So we can still give them abiraterone. We can still give them enzalutamide. Suppose someone has received the oral drugs earlier. Suppose the disease increases, we can still give them docetaxel later. But the patient should be fit by then. So if a 75-year-old has on abiraterone has a relapse when he is 79, I don't think that docetaxel may be a valid option depending on the general fitness of the patient, obviously. So important to choose the therapy, important to consider everything and then start the medicine. But essentially, please remember, in metastatic prostate cancer, just ADT is not enough. That is the key message. You have to add something in the newer era. Next slide, please. So one other very important thing is genetic testing in prostate cancer. So this is an upcoming field. Prostate cancer is associated with a family history. So suppose you have a strong family history, especially in high risk and metastatic prostate cancer, you have to consider genetic testing. This is something new. And next slide, please. Another gene you might be familiar with in breast and ovarian cancer, BRCA, especially more specifically BRCA2, is associated with prostate cancer also. So like as you can see on the slide, if you have this BRCA mutation, your DNA repair will get will be problematic. And you have a normal cell lower left corner which has very few mutations, and if you have BRCA, you will have a lot of mutations inside the cells because the DNA repair is not it does not have a proper pathway. And next slide, please. We have drugs targeting that called PARP inhibitors, which are sometimes used in prostate cancer. PARP, poly ADP ribose polymerase, which are again oral pills which have been approved. So beyond docetaxel, beyond abiraterone, beyond enzalutamide, they have been approved in prostate cancer treatment. Bone health is a very important thing in prostate cancer. So ADT can cause osteoporosis. You can give bisphosphonates to prevent bone loss depending on the DEXA scan. And in castrate-resistant prostate cancer with bone mets, you use a drug called denosuzumab, which is a subcutaneous injection. It inhibits the action of osteoclasts, which is there in the cartoon, and it prevents the skeletal-related adverse events like fractures. Or you give zoledronic acid, which is the bisphosphonate which we use in osteoporosis also. So bone health is also important in prostate cancer, like hormonal treatment, like your chemo, like your anti-androgen. Bone health should also be considered. Next slide, please. So summary, androgen deprivation remains the mainstay of systemic treatment. ADT, orchidectomy, or injections. Injections may though GnRH agonists or antagonists. Flare with agonists should be remembered. In upfront metastatic setting, ADT is combined with drugs like docetaxel, abiraterone, or enzalutamide. Proper selection and sequencing is the key. We have to look at side effects. We have to look at everything else also. And remember genetic counseling, which is upcoming, and drugs for specific mutations in prostate cancers like PARP inhibitor, PARP, which might be the next big thing in prostate cancer. Next slide, please. So going back to our patient, the gentleman was offered ADT. He chose bilateral orchidectomy. He was counseled for additional treatment. He did not want chemotherapy, and in view of uncontrolled diabetes, because steroid will again shoot up his sugar, he was started on enzalutamide 160 milligram per day, which does not require steroids. After 2 months, from 100 ke upar tha, 109 tha, ESA has come down to 12. There is a history of breast cancer in maternal aunt, so BRCA mutation. So he has been, might be there. So he has been counseled for genetic testing. Thank you so much.
Thank you very much, Pai sir. It was a wonderful session. And are there any questions, Siddharth?
Thank you.
There are no questions, I think
to
so.
the IMA, and thank you, Intas.
Yeah.
Thank you so much. Thank you so much, sir. Bye.
Thank you very much, Rohit Pai sir. Thank you. Friends, I just want to make an important announcement. IMA Mumbai branch. We have our secretary, Dr. Pankaj Bandarkar, who is the secretary for IMA Maharashtra State for the consecutive second year. So I congratulate Dr. Pankaj Bandarkar. Also, we have Dr. Prakash Borana, who was our president 2 years back, last year. He has been elected as the senior vice president, IMA Maharashtra State. So I congratulate both of them for this achievement. And now I request Dr. Sachin Patarkar, our Assistant Secretary, IMA CGP Sub Mumbai Sub Faculty, to give the vote of thanks.
Yeah. Good afternoon, everyone. I would like to thank all our speakers of the today's webinar, Dr. Neeta Varti, Dr. Nimit Shah, Dr. Ashay Shingare, Dr. Rohit Pai, Dr. Dilip S. Nikam. I also thank our knowledge partners for the day, Sir H.N. Reliance Hospital and Sanofi Empowering Life, Entas Oncology, Mr. Dipen Mehta from the DigiShield, and Mr. Chirag from the DigiShield, who have given us the platform for this webinar and handle all technical details. At the same time, I also thank our observer for the day, Dr. Yogesh Shah, and all the delegates who had attended this webinar in large numbers. I thank you, everyone, again. Thank you very much.